1st July, that was Friday, being a working day, we thought it's better to conduct this program today, being Sunday, so that many members and their family can participate in these various events which have been kept to entertain the audience. You know very well Doctor's Day being celebrated in India on July 1st. It is observed, in order to honor late Dr. B.C. Roy, Vidhan Chandra Roy, who was a doctor, eminent surgeon, physician, he was a politician, educationist, then social worker and social reformer as well. And during his chief minister, he was the second chief minister of West Bengal. During his chief minister posting also, period also, he used to serve the people. At least I think 2 hours a day he used to spend in his clinic seeing the patients. So that much attention, or he had a lot of regards or a lot of affection on his patients. So, and the beauty is he was born on July 1st and also expired on July 1st. So, IMA, Indian Medical Association, has decided to celebrate this day, July 1st, from 1991 onwards. And whoever have served the health department, especially the doctors who have served a lot, selfless service they have given to the patients, and that has been recognized since then every year, and B.C. Roy Award has been given or awarded accordingly. So today we are all here to celebrate this Doctor's Day, and to begin with the program, I think before we start the cultural events, it is our duty to light the lamp and invoke the blessings of the God.
Observing for the first time Bharatanatyam performed in this kind of music. A big round of applause for that. We now invite the audience to savor the fragrance of coastal Karnataka, our Tulu Nadu, with the rendition of a song in Tulu by Dr. Julian Saldana, physician, District Mangalore Hospital. Dr. Saldana will be singing one of his favorite songs, Mokila Singari.
Mokila Singari, Untuge Vaiyari, Mokila Singari, Untuge Vaiyari, Yamule Kaavule Male Kopala, Oh Munne Na More Tae Kopala, Mokila Singari, Untuge Vaiyari.
because it's sung in Punjabi, Pakistani Punjabi. The original singers were Ali Seth and Shagil. Thank you, Dr. Saksham and Dr. Nihal, for the wonderful foot tapping music.
Thank you, both of you, for that wonderful number. It shows what we can each learn from each other if we had more love than war. Thank you, Saksham and Nihal.
Next, from the field of music, we go to the field of dance with a performance from the young chanters of Yenipoya Medical College. Ladies and gentlemen, the young chanters are here to enchant you with their mesmerizing notes.
There's something different about this girl. The way she moved, her hair, her face, her lines, divinity much.
This is an old song from the movie Gora Aur Kala, sung by Mohammed Rafi in the movie Radhika Kumar Hinnamalani. एक नाम एक दिल है तू मेरे सपनों की रानी बनेगी एक ना एक दिन ये कहानी बनेगी तू मेरे सपनों की रानी बनेगी मैं तेरा दीवाना बनूंगा रानी तो मेरी दीवानी बनेगी एक ना एक दिन ये कहानी बनेगी तो मेरे सपनों की रानी बनेगी ओ एक ना एक दिन ये कहानी बनेगी तो मेरे सपनों की रानी बनेगी चैन लूटा है नींद लूटी है ऐसे मौसम में हमसे रूठी है चैन लूटा है नींद लूटी है ऐसे मौसम में हमसे रूठी है ये तेरे हाथों की अंगूठी ये मेरी पहली निशानी बनेगी एक ना एक दिन ये कहानी बनेगी तो मेरे सपनों की रानी बनेगी ये गुस्सा तू भूल जाएगी तेरे होठों पे हंसी आएगी ये गुस्सा तू भूल जाएगी तेरे होठों पे हंसी आएगी ये आज हो या कल हो ये होगा ये मेरी मेहरबानी बनेगी एक ना एक दिन ये कहानी बनेगी तो मेरे सपनों की रानी बनेगी मैं तेरा दीवाना बनूंगा रानी तो मेरी दीवानी बनेगी एक ना एक दिन ये कहानी बनेगी तो मेरे सपनों की रानी बनेगी ओ एक ना एक दिन ये कहानी बनेगी तो मेरे सपनों की रानी बनेगी थैंक यू वेरी मच थैंक यू वेरी मच
Thank you, Dr. Anand Prabhu sir, for that wonderful number. It took us back to the Mohammed Rafi era. Now, as we have cleared the stage at 5 o'clock sharp for RJ Arpit, so the remaining part of the cultural program will be held after this stand-up comedy. Ladies and gentlemen, we have now been witness to the performance by our own IMA members who have talented but still amateurs. So, the next program will be performed by the professional performer. He is none other than RJ Arpit, who will be now coming forward to tickle your funny lips. Over to RJ Arpit.
This Mangalore airport. Okay, so before I start, I just want to know what language would be easier if I conversate English is good enough? Tulu? ಓಕೆ ಏನ್ ಜನಕ್ಕೆ ತುಳು ಬರ್ಬಿಟ್ಟು ಡಾಕ್ಟರ್ ನಮ್ಮಲ್ಲಿ ತಾಮಸರ ಮಲ್ಪೇರ್ನೇನೆ ಏದು ಜನಕ್ಕೆ ತುಳು ಓ ಬರ್ಬಿಟ್ಟು ನೈಸ್ ವಾಟ್ ವಾಸ್ ಇಟ್ ದಿಸ್ ಇಸ್ ಎಮರ್ಜೆನ್ಸಿ ನಾವು there I come to the next joke ಇನಿಯಲ್ಲ ಆಕ್ಸಿಡೆಂಟ್ ಆದ ಟ್ರಾಮಾ ಕೇರ್ ಕೊಂಡ ಪೇಷಂಟ್ ಇಡೋದಾದ ಬಂದಿರೋ ಒಂದು ಚೆಪ್ಪಲೆ ಡಾಕ್ಟರ್ ಡ್ಯಾನ್ಸ್ ಮಾಡ್ತಾರೆ ಡಾಕ್ಟರ್ಸ್ ಡೇ ಬಂದೆ ವಾರ್ಷೋಕ್ ಪದ್ಯಂಡು ಕೊಡ್ತು ನೀರಿನ ಅಡಿಗೆ ಟ್ರಾನ್ಸ್ಫರ್ ಮಾಡ್ಬೇಕು ಪುಲ್ಲೇರ ಅದ ಕೂಡಲೇ ಡಾಕ್ಟರ್ಸ್ ಇನಿ ಪುಲ್ಲೇರ ಅದು ಸಡನ್ಲಿ ವರಿಡ್ ಪುನಃ ರಾತ್ರಿಗೆ ಒಂದು ತೋಜು ಕಮ್ಮಿ ಕೆಲಸ ದೇ ಹ್ಯಾವ್ ಅ ಟೆಂಡೆನ್ಸಿ ಟು ಹಿಟ್ ಪೀಪಲ್ ಸೊ ರಿಮೆಂಬರ್ ಇಫ್ ಯು ಡೋಂಟ್ ಲಾಫ್ ಎಟ್ ಮೈ ಜೋಕ್ಸ್ you know the best part, next time I travel with JP only, that an arena audience will pull on. Our first filter, I don't know because 99% of the time in Mangalore when you crack a joke, nobody laughs. But if in audience 2 people laugh, then it is contagious. Everybody's like, something is funny, then they are laughing, we'll also laugh. I thought it was Doctors' Day celebration here today. Then later on I realized it is India's Got Talent Doctors version. I'm glad. I'm really glad. You know what? I always wanted to become a doctor. I always wanted to become a doctor because it doesn't have mathematics in it. I was only looking for a profession where there is no mathematics. Then I realized doctors are the pura mathematics here, calculations of how to keep people alive. Right? But it's nice. It's nice. You know what? We performers and doctors have a lot of things in common in this country, India. Stand-up comedy, especially post-COVID, we saw a trend. Patients are assaulting doctors and arresting stand-up comedians. So we have a lot in common. Recently, I was a corporate event for a particular kind of profession. And I did book every time I do stand-up, I have 4 questions. Are you okay with all kind of jokes or you will get offended by something? First are you okay with strong words or should I use nice little words? Strong word. Are you okay if you don't understand the jokes but others are laughing? Last one. Are you okay to still pay me if you don't like the show? But one person in the audience got offended and he said we are not paying, and I couldn't even file a case against him because it was lawyer's show. So next time in corporate event, what I decided was that payment advance I went there. Jokes went on well. Even people liked the jokes. The professionals, but as usual, they like the joke too much. Bar counter open, and a joke I just said, people started laughing. And even I went there after the show, 3-4 drinks, and then after the parking guard open, drink and drive the case for it. Police function. So the next year, not all events went sad. The event went super good, which professional group. So the event was for CAs. Kudla the CA Nagal event was there. And I was not sure, CA Nagal, what jokes to crack. Right? And so they see the bank, the balance sheet. Right now it is doctors. I thought I had a medical report. But it was so bad. So before we start, a little crowd work. Can I know what kind of doctors we have here? No, that is a very simple answer. I feel like I've come to Sanjini Multi-Speciality Hospital. Dentist, no, but still to be specific. Any doctor who believes that mine is a very unique. Nobody? I just read it over there. Plastic surgeon I will need your help. Plastic Please. Anesthesia doctor. Oh, if you don't like the joke, just inject. I will be sleeping in one corner. Oh, No, I was just worried, इन्हीं jokes इस टाइप से ना, मेरा क्या हाल होने वाला है? Right? कुडला डे को hospital वो भी लेके ले जाए. Because first patient was, उम्मीद ना, मॉर्निंग बारी बात है ऐसे. And by default, because of profession, you are allowed to use sharp objects. Right? बाकी वो profession लग जाता है. But if you see, this profession, with all due respect, nobody argues with the doctor most of the time, When the patient if you tell him, sir, you have high BP, your BP is supposed to be 120, it is at 180. Nobody argues. Okay, better profession, bandar admin. Sir, look touch, inch na. Doctor not get nobody. You can't argue with the doctor. Sir, no, never has it happened. But I believe medical is the most, what do you call it? Underrated profession, because people know, that's my opinion. Doctor there, that's my opinion. And most of it is done by movies. Right? Doctor ने बोल पड़ा, please doctor बचा लो इसको, इंचा बचा लो इसको, ये तबे ले क्लच हाल आता है, गाड़ी सीज आता है, गैरेज एक बोल पड़ रहा है, sir बचा लो इसको. But we tell it to the doctors every time. And you know, when this scrap piece इतने वाला जब को पता है, doctor ने repair मत कर ले. अबे हालत इतना कोड़े पता चला को repair मत कर पाना. Never has happened. On that note, it brings me to a very funny topic. Imagine there are multiple types of doctors, right? Not similar. General physicians will learn, neurologists will learn, cardiologists will learn. So in an imaginary world, one day there happened to be a discussion on who is the better one. Okay? Imaginary world. Yenna safety one. Niche aate is imaginary. So first, the doctor ENT na korbanna regular means. Una tuijinda gottappinencha, feel ajinda gottappinencha. Appa dermatologist wonder feel up in a department engal todu. We have the skin. Equal better. Adanaga the internal organs the doctors nakulo really start. Apple bande renkulla, brain double bande renkulla, spine double bande renkulla, heart double bande renkulla. So the discussion was going on. It was a very big discussion. Other doctors nakulo, "Arey hum hai." Adanaga barita neighbor auntie batte. Neighbor auntie batte to hear the discussion on it. Then she realized that when the patient kolonder and sided kolonder, the different departments of doctors are discussing who is the best. So neighbor auntie did the best thing what she does, but the patient again did. That's the problem. Now the patients they have a tendency. Like direct problem So if you want to reach Jyoti signal from PVS, what's the road you will take? Right? But patients are not like that. They'll first go to Urva market. From there they'll go to Kottara. From there they'll get stuck in KPT. Then they go to Nantur for no reason. From there they'll come to Jyoti. So same thing this patient did. This patient is under the Guttuju Asadeka. Kanda Lakanagada, Tirunich, Madenan Badapinich, Ratri Nidrabarpinich. Now all the doctors were fighting, telling that equal best are all silent. I mean, what MBBS to E type the description, you know, good thing is exactly. Because now every department has a stake in this, no? So suddenly the neighbor auntie did the best. Are a top home problem there. I mean, share. Make the document is there. Nenga to pandit rule. Ji kasha burger kaande madhyana bhaiya parle. Adu ko chicken depe, jimmy depe, jigopu depe, jopu depe, jhar depe, jishu depe. So that is what I think you also would have faced. Every department of doctor is there, but final ji kasha madhyana. Right? See, when we had COVID, everybody really, we all understood how important it is to have a doctor in the family. Because everybody is scared. It suddenly felt, I have a lot of doctor friends. And so it was very nice, Materala phone they are all from Mumbai and Bangalore, so everybody is getting called, bro, bed child. Furniture because everybody wanted a bed. That day we realized how important doctors are. Right? But after that, the vaccinations came in. Vaccination became like, I'm sorry to tell, but Yanoji, Kudladuchi, Molla jacket, vaccination hodite. And I had paid also like an idiot because I was scared for life. अब vaccination इंचे तो बनाने doctors ना कोई डांट के बोल देते हैं, आ जाओ, 10 points. 50. Bullseye! So after the vaccination, suddenly the public, they got confidence. First corona, now corona corona. The first time when people went to doctors and doctoring corona is jata. Ithe jana doctor corona nija unda parle. Unmata scam. That's the level we have come to. Suddenly we all became very confident. Nanka corona the body is. So COVID time we all realized how important doctors are. But the fun fact remains, see, I'm not a doctor, but I think I can connect with you here because we all deal with the same people. My grandparents era Tupunda family doctors in there. When it came to my parents' era, that dropped to 4 doctors in the family. And right now in my cousins, if I search and see, there is not even a single doctor. Why? Because slowly our family realized that patients harami hote hain. Right? No, listen, I'm not going to tell it outside. Ye wala cut kar do. होते कि नहीं होते? बोलो होते कि नहीं होते? JP you recorded that, no? Next to that, consultation free. No, but seriously होते हैं. You know why? You try hard to save their life. You try hard to cure them. Other put a doctor and Badhu Prata doctor. Once they are all fit and fine, they are out. He's still there sleeping or little limping. Somebody comes and say, Boka, Prakashna Incholar. Hi, I'm sure. Aspatrit Patu Donchi thing or it. Yenchi pocket after the Marla in Red Lacha, but can sorry. Has it happened to you? Also, the same patient, it's like an optimistic patient. The conversation in our language is funny. I go to see my friend in a hospital. And how does he look like? I know he's bedded Jepda and here the pipes and wires connect. He looks like middle class family that he led. Binner Badupana, pipe busted, mother mobile charge. So many things connected to him. And he's lying down. I go to Baritonji TV there, but TV is some old black and white TV. In fact, kali lines matra pogun. Beto the channel Huh? This is the difficulty of cracking jokes to doctors. They'll tell the exact word. Yan hoge yan panda Star Plus panda. Ola serial to kada panda ho panda yan hope. So he was lying down, okay, and it looks really serious. I know my observation skills are that when people are sitting normal, they are fine. When they are lying down, they are not fine. When there are too many things connected to them, they are definitely anchi pore ready. They are planning. Not a doctor. So, but I woke up and I opened the door and first of all this side of USB charger I was like, okay. But Kudla Donji Abhyas that whenever you meet somebody, you ask them, Boka, Encholar, right? No, this is a wrong thing to do. I asked for it, I see you the Kandi and Boka Encholar and his immigration. Yeah, it's okay. Boka Enchina charging you on the other side. On that note, I have a small task to be done. Both of you are doctors? Both of you, right? So then I got worried because I have a family of doctors who's good friends also. Not my family, my friend and his mom, his dad, his brother. In their family, it's like when anybody gets married, the first criteria is the hospital. So I was just told by one of my friends, right? It's your job. Like, for example, if a cop tells, it is like, tum log station mein gana bajate ho. The same thing happened to me. Tum log operation theater mein gana bajate ho. I was perplexed. He said, because we being youngsters, we know that Saturday ko ek hi jagah pe music bajta hai, jahan pe daru. Excited. Isn't an exciting thing, right? Something that you never knew. Being a patient also, it would be nice. Sometimes too much of cough and voice goes out. So, I can tell you practice. Like such like suddenly surgery and then like for audience like this, I mean that was good laughter, which means I'm an average comedian. But whenever there is a good show, people are laughing, we say killing it. Kill it. Coming from a family where even grand-uncle and grand-aunt were doctor, my grand-uncle was a district surgeon once, grand-aunt as well. So I know, it's a big thing. The charity that you guys are doing, I'm really curious to understand. Isn't it? Like, you would believe when I was a kid, my handwriting was so bad, half my family went to doctor banega. I mean, that can be a mode of judgment, like doctors handle. Show towards the last leg, in fact, the last part of it, I want to prove that wrong. I have given a check here to both doctors. I am going to read out what they have written. Their names are very easy.
That wonderful presentation.
Next, we have a performance from on the Bollywood fusion dance. Over to
स्वैग से करेंगे सबका स्वागत स्वैग से करेंगे सबका स्वागत
Romeo, Romeo, कलिए Romeo, होए शब्द वाले सारे के सारे बरबिया. Romeo, Romeo, भाई की बेबियो, काहे गए बड़े हो बिल्कुल नहीं बनाती. ऐसी पैर गलत बेटा हमेशा हुस्न से भरी.
Would have given all the Bollywood stars a run for their money. Ladies and gentlemen, if you agree, I think they deserve a big round of applause. Ladies and gentlemen, next we have another performance by the IMA members from ANMI Medical College who will be taking us into the land of melody. We invite on stage the melody healers for the group song.
is another Bollywood folk duet dance by the IMA members of Father Medical College, Dr. Pragna Virendra and Dr. Ekta Shetty.
Hidden in our members. To bring this talent forth, we have Dr. Sandhya and Ruth, a combination of AJ and Shema Medical College, who will be enacting a skit, Vaidya Suradigaru.
ವೈದ್ಯ ವೃತ್ತಿಯಲ್ಲಿ ಕಚಗುಳಿ ಇಡುವಂತಹ ಹಲವು ಸನ್ನಿವೇಶಗಳಲ್ಲಿ ಕೆಲವನ್ನು ನಾವು ನಿಮ್ಮ ಮುಂದೆ ವೈದ್ಯ ಸುರುಳಿಗಳ ರೂಪದಲ್ಲಿ ಪ್ರಸ್ತುತಪಡಿಸಲಿದ್ದೇವೆ. ನಿಮ್ಮ ಮುಂದೆ ಪ್ರಸ್ತುತಪಡಿಸಲು ಮೊದಲ ಸುರುಳಿಯಾಗಿ ಮಧುಮಗಳು. ಚರ್ಮರೋಗ ವೈದ್ಯರ ಹೊರರೋಗಿ ವಿಭಾಗ ದೃಶ್ಯ 1.
ಮಗಳು ಈಗಿನ 2 ವರ್ಷ ಮದುವೆ ಐತಿ ಮುಗ್ದಾಗೆಲ್ಲ ತಿಂಡಿ ಮಾಡ್ಬೇಕ್ರಿ.
ತಿಂಡಿನ ನಾವು ತಿಂಡಿ ತಿನ್ನುದು ಇದೆಂತ ತಿಂಡಿ ಬರುದು ಅಂತ ಹೇಳಿದ್ರೆ
ತಿಂಡಿ ಅಲ್ಲ ಅಮ್ಮ, ಅದು ರಿಚಿಂಗ್.
ಓಕೆ ಸರಿ ಸರಿ.
ಆಕಿ ಇದು ಮದುವೆ ಐತಿ ಅಂತ ಹೇಳಿ ಅದೇನೋ ಬ್ಯೂಟಿ ಪಾರ್ಲರ್ ಅಂತೆ ಅಲ್ಲಿ ಹೋಗ್ಯಾರ. ಅದೇನೋ ಮುಖಕ್ಕೆ ಬಂದ್ಕೊಂಡು ಕೂತ್ಕೊಂತಾರಲ್ರಿ ಅಂತ ಅಂತಾರ ಬಂದ್ರೆ ಫೇಸ್ ಪ್ಯಾಕ್. ಅದ ಫೇಸ್ ಪ್ಯಾಕ್ ಎಲ್ಲ ಹಾಕೊಂಡಾಳ. ಅದೆಲ್ಲ ಅದಷ್ಟೇ ಅಲ್ರಿ, ನಮ್ಮ ಕಾಲದಾಗಿಂದ ಏನಿಲ್ಲ ನೋಡ್ರಿ, ಒಂದು ಅರಿಶಿನ ಹಚ್ಕೊಂಡು ಬತ್ಕೊಂಡಿದ್ವಿ, ಚಕ ಚಕ ಅದು ಹೊಳಿತಿದ್ರು. ಇವಾಗ ಇದೆಲ್ಲ ಬಂದ್ಬಿಟ್ಟೈತಿ. ಅದಷ್ಟೇ ಅಲ್ಲ, ಈ ಗೂಗಲ್ ಏನೇನೋ ನೋಡಿ ಏನೇನೋ ಆಯಿಂಟ್ಮೆಂಟ್ ಬೇರೆ ಹಚ್ಕೊಂಡಾಳ ನೋಡ್ರಿ. ಹಂಗಾಗಿ ಭಾರಿ ತ್ರಾಸ ಆಗ್ಬಿಟ್ಟೈತ್ರಿ.
ಅದೇ ಈಗೆಲ್ಲ ಇದೇ ಮಾಡುದು. ಮದ್ವೆಗೆ 2 ವಾರ ಬರ್ತಿರಿಲ್ಲ, ನಾನು ಚಕ ಅಂತ ಮಾಡಿಲ್ಲ, ಎಲ್ಲಿಂದ ಮಾಡುದು? ನಾವೇನ್ ಮ್ಯಾಜಿಕ್ ಮಾಡುದಾ? ಅದ್ರ ಮೇಲೆ ಗೂಗಲ್ ಸರ್ಚ್ ಮಾಡ್ಕೊಂಡು ಏನೇನೋ ಮುಖಕ್ಕೆ ಮೆತ್ಕೊಂಡು ಬರ್ತಾರೆ, ಮತ್ತೆ ಏನಾದ್ರು ಮಾಡ್ಕೊಂಡು ಬರ್ತಾರೆ. ನೀವು ಈಗ ನೋಡುವ ಏನಾಗಿದೆ ಅಂತ. ಸರಿ, ಅಲರ್ಜಿ ಆಗಿದೆ ಅಂತ ಕಾಣ್ತದೆ. ನಾನು ಮದ್ದು ಬರ್ಕೊಡ್ತೇನೆ, ಮಾತ್ರೆ ರಾತ್ರಿ ಮಲಗೋ ಮುಂಚೆ ತಗೊಳ್ಳಿ. ಆಮೇಲೆ ಒಂದು ಆಯಿಂಟ್ಮೆಂಟ್ ಬರ್ಕೊಡ್ತೇನೆ. ಸೊ ಏನು ಹೆಸರು? ಓಕೆ, ಸರಿ. ಇದನ್ನ ಇದು ಬೇರೆ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್. ನಿಮಗೆ ಗೂಗಲ್ ಸರ್ಚ್ ಮಾಡಿ ಬರುವಾಗ ಸೈಡ್ ಎಫೆಕ್ಟ್ಸ್ ಇದ್ದೇನಿಲ್ಲ, ಅಲ್ಲಿ ಬೇಕಾದೆಲ್ಲ ಹಚ್ಕೊಂಡು ಬರ್ತಾರೆ. ಮತ್ತೆ ಇವರಿಗೆ ಸೈಡ್ ಎಫೆಕ್ಟ್ ಬೇರೆ. ನಾವು ಇಷ್ಟು ವರ್ಷ ಕಲ್ತಿದ್ದೇವೆ, ಕಲ್ತು ಇಷ್ಟೆಲ್ಲ ಮಾಡಿದಾದ್ಮೇಲೆ ಇವರಿಗೆ ಈಗ ಸೈಡ್ ಎಫೆಕ್ಟ್ ನಮ್ಮದಕ್ಕೆ ಭಾರಿ ಚಿಂತೆ. ಗೂಗಲ್ ಸರ್ಚ್ ಮಾಡುವಾಗ ಯಾರೋ ಏನೇನೋ ಬರ್ದಿರ್ತಾರೆ, ಅದಕ್ಕೆ ಯಾವ ಚಿಂತೆ ಇಲ್ಲ ಅವರಿಗೆ.
ಡಾಕ್ಟರ್ ಅವರ ನಿಮ್ಮ ಕಡೆಯಿಂದ ಬೇಗ ಒಂದ್ ಸ್ವಲ್ಪ ಚೆನ್ನಾಗಾದ್ರೆ ನಮ್ಮ ಮದುವೆ ಅಂದಿತಿ ಚಕ್ಕ ಅಂತ ಹೊಡೆದ್ರೆ ಭಾರಿ ಉಪಕಾರ ಆಗ್ತೈತ್ರಿ. ನೋಡ್ರಿ, 2 ತಾರೀಕಿಗೆ ಮದುವೆ ಐತಿ, ನೀವು ಒಂದು ಮದುವೆಗೆ ಬರ್ಬೇಕಾಯ್ತಾ?
ಓಕೆ, ಕ್ಲಿಂಚನೆ ಮಾತಾಡ್ ಬಿಡುವಾರ ಅಂದು ಕಾಸು ಬಂದ ಜಿಜ್ಜಿ.
ಡಾಕ್ಟ್ರೇ?
ಹೌದು, ಮತ್ತೆ
ಎಷ್ಟು?
500 rupees.
500? ಒಂದ್ ಕೆಲಸ ಮಾಡ್ತೀನ್ರಿ, ನಾಳೆ ಸಂಜೆ ಮುಂದೆ ನಿಮ್ ಕ್ಲಿನಿಕ್ಗೆ ಕಳ್ಸಿದ್ರೆ ಬರ್ತೇನ್ರಿ. ಈಗ ನನ್ನ ಹತ್ರ ಅಷ್ಟು ರೊಕ್ಕ ಇಲ್ರಿಪ್ಪ.
ನೀವು ಗೂಗಲ್ ಸರ್ಚ್ ಎಲ್ಲ ಮಾಡ್ತೀರಲ್ಲ, ಹಾಗೆ ಒಂದು ಗೂಗಲ್ ಪೇ ಮಾಡಿಬಿಡಿ.
ಬೇಗ ಹುಷಾರಾದ್ರೆ ನಮ್ಮ ಕಾಣಂಗಾದ್ರೆ ಮಾಡಿದ್ರೆ ಒಳ್ಳೇದ್ರಿ ಸರ್.
ಓಕೆ ಓಕೆ, ಥ್ಯಾಂಕ್ ಯು. ಸದ್ಯ ಗೂಗಲ್ ಪೇ ಇದನ್ನ ಬರುತ್ತೀವಿ ನಾವೀಗ. ವೈದ್ಯ ಸುರಳಿ 2ನೇದು ಕಣ್ಣಿನ ವೈದ್ಯರ ಹೊರರೋಗಿ ವಿಭಾಗ, ಅಜ್ಜಿ ಪುರಾಣ.
ಟೆಸ್ಟ್ ಮಾಡ್ಲಿಕ್ಕೆ ಎಲ್ಲ ಹೈಟ್ ಬೇಕಾಗುತ್ತೆ. ಏನ್ ಬೇಕಿತ್ತು ನಿಮಗೆ?
ಕನ್ನಡಕ
ಎಂತ ಕನ್ನಡಕ ಇತ್ತ ತಂದಿದ್ದೀರಾ?
10 ವರ್ಷದಿಂದ ಹಾಕ್ತಿದ್ದೆ.
10 ವರ್ಷದಿಂದ ಒಂದೇ ಕನ್ನಡ
ಸರಿ ಇತ್ತು ಡಾಕ್ಟ್ರೆ.
ಆಯ್ತು.
ಅದು ಬೆಂಗಳೂರು ಹೋಗುವಾಗ
ಬೆಂಗಳೂರು ಬಾತ್ರೂಮ್ ಬರ್ಪುಡು ಅಡ ಇನ್ನ ಗೊತ್ತಾಗ್ಬಿಸಿ ಅಲ್ಲಿ. ನಮಸ್ಕಾರ. Where are you from? Where do you study?
I'm from Place International.
Okay. Okay. ಈಗ ಕನ್ನಡಕ ನಿಮಗೆ ಚೆಕ್ ಮಾಡಿಸೋಣ?
ಹೌದು, ಈಗ ಬಲ ಕಣ್ಣು ಮೈ ಕಾಣ.
ಇನ್ನೊಂದು ಕನ್ನಡ ಕಾಣಿಸ್ತದ?
ಸ್ವಲ್ಪ ಸ್ವಲ್ಪ ಕಾಣ. ನೋಡಿ,
ಈಗ ನಾನು ಸ್ವಲ್ಪ ನೋಡ್ತೀನಿ. ಅಲ್ಲಿ ನೋಡಿ, ಬೋರ್ಡ್ ಕಾಣಿಸ್ತದಲ್ಲ? ಅಮ್ಮ ಅಮ್ಮ ಇಲ್ಲಿಂದ ಅಲ್ಲಿಗೆ ನಿಮಗೆ ಕಣ್ಣು ಕಾಣಲಿಲ್ಲ ಅನ್ನೋದಲ್ಲ, ಅದು ಕನ್ನಡ ಓದಕ್ಕೆ ಬರ್ತದಲ್ಲ. ಮತ್ತೆ ನಿಮ್ಗೆ ಯಾವ್ದು ಇಂಗ್ಲಿಷ್ ಬರ್ತದ? ಆಯ್ತು, ಈಗ ನಾನು ನಂಬರ್ ಹಾಕ್ತೇನೆ. ಅದು ಒಂದು 7 ನಂಬರ್ ಮುಂದಕ್ಕೆ ಬರ್ತದಲ್ಲ? ನಂಬರ್ ಅಲ್ಲ, ದುಡ್ಡು ಎಲ್ಲ ನಂಬರ್. ಹಾಗಾದ್ರೆ ನಂಬರ್ ಯಾವ ಸೈಡ್ಗೆ ತಿರುಗಿದೆ? ಬಲಕ್ಕ ಇರತ್ತ? ರೈಟ್ ಆರ್ ಲೆಫ್ಟ್? ಹಲೋ ಮೇಡಮ್, ನೋಡಿ ಅಮ್ಮ, ಅವ್ರದ್ದಲ್ಲ ಕಣ್ಣು. ನಿಮಗೆ ಇಂಗ್ಲಿಷ್ ಬರ್ತದೆ? ನೀವು ಕನ್ನಡ ಕಲಿಸ್ತೀರಾ ಅಂತ ನನ್ನನ್ನೇ ಕೇಳ್ತೀರಾ? ಓ ಮೈ ಗಾಡ್. வெங்கம்மா இது ஸ்டைல பண்ணணும். வெங்கம்மா புது முடிச்சிட்டு ಅಲ್ಲಿ ಡ್ರಾಸ್ ಮಾಡಿ ಕೊಡ್ಬೆ and handwriting ಹೋದರೆ ಎಲ್ಲ ಬರ್ತು. ಬರ್ತಾ ಇಂಗ್ಲಿಷ್ ಇದೇ ಬರ್ತದಲ್ಲ? ಅಲ್ಲೇ ಇದು ಡ್ರಾಪ್ಸ್ ನಿನ್ನ ಪ್ರಿಸ್ಕ್ರಿಪ್ಷನ್ ಡ್ರಾಪ್ಸ್ ಬಲ್ಪು ಮಧ್ಯರಾತ್ರಿ ಮೂಜಿ ಕೊಟ್ಟು ಮಾಡಿ
ಬಲ್ಲತ್ತ ಕಣ್ಣೇ
ಇದು ರಾತ್ರಿ ಕಣ್ಣು ಉಂಟಾ?
ಬಲ್ಲತ್ತ ಮಯ ಜಾಸ್ತಿ.
ಮಯ ಜಾಸ್ತಿ ಬರೋದು, ಜಾಸ್ತಿ ಬರೋದು. okay? I'm sure she's not understanding English. I'll tell it to you.
Yes.
I don't know how you manage her. Okay, yes. The dogs is little. Please give it to her.
ఒక డాక్టర్ యాన్ పూర పరీక్ష ಮಾಡ್ತಾರೆ ಪಾಸ್ ಫೇಲ್
ಏನ್ ಪಾಸ್ ಯಾರು ಅದಕ್ಕೆ ಒಂದು 200 ರೂಪಾಯಿ ತಿಳಿ ಅಮ್ಮ ಕನ್ನಡಕ್ಕೆ ಇರುವ ಅಗತ್ಯ ಬೋರ್ಡ್ ರೆಡಿ 10 ರೂಪಾಯಿ ಕೊಡಿ 200 ರೂಪಾಯಿ
ಅದು ನೋಡಿ ಕನ್ನಡ ಎಲ್ಲ ಒಂದೇ ಅಲ್ಲ ಡಾಕ್ಟರ್ ಗೊತ್ತೇ ಆಗುದಿಲ್ಲ
ಕಲರ್ ನೋಡಿದ್ರೆ ಸೈಜ್ ಗೊತ್ತಾಗ ಸೈಜ್ ಮಲ್ಲ
ತುಂಬಾ ಥ್ಯಾಂಕ್ಸ್ ಇನ್ನು ಕನ್ನಡಕ್ಕೆ ಎಲ್ಲಿ ಮಾಡಿಸ್ಬೇಕು
ಕನ್ನಡಕ ರಿಸೆಪ್ಷನ್ ಅಲ್ಲಿ ಹೋಗಿ ಅಲ್ಲಿ ಅವ್ರು ಹೇಳ್ತಾರೆ ಪ್ರಿಸ್ಕ್ರಿಪ್ಷನ್ ತಗೊಂಡು ಮಾಡಿಸ್ಬೇಕು
ಮತ್ತೆ ಬರೋದು ಪರೀಕ್ಷೆಗೆ
ಒಂದು ವಾರ ಬಿಟ್ಟು ಬನ್ನಿ ಕನ್ನಡದ ಬಾಕಿ ಇದ್ರು ಅಂತ ಹೇಳಿ
ಮೂರನೆಯದು ಚೌಕಾಸಿ ಕೇಸು ಶಸ್ತ್ರಚಿಕಿತ್ಸಕರ ಅನುಭವ.
ಹಲೋ ಡಾಕ್ಟರ್ ಅಮೃತರ?
ಹೌದು, ಯಾರಿಗೂ ಮಾತಾಡ್ತಿರೋದು?
ನಾನು ಪ್ರಮೋದ್ ಅಂತ ನಿಮ್ಮ ಕ್ಲಿನಿಕಲ್ಲಿ ಕೆಲಸಕ್ಕೆ ಬರ್ತಾರಲ್ಲ ಅಪ್ಪಿ ಅಕ್ಕ, ಅವರು ನಿಮ್ಮ ನಂಬರ್ ಕೊಟ್ಟರು.
ಓಹೋ, ಬಾರಿ ಒಳ್ಳೆದೆ. ಏನಾಗಬೇಕಿತ್ತು ಪ್ರಮೋದ್ ಅವರೇ?
ನೀವು ಫೈಲ್ ತೆಗಿತೀರಾ ಡಾಕ್ಟ್ರೇ?
ಫೈಲ? ಯಾವ ಫೈಲ್ ಬೇಕಾಗಿತ್ತು ನಿಮಗೆ? ನಮ್ಮಲ್ಲಿ ನಮ್ಮ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ MRD ಸೆಕ್ಷನ್ ಅಂತ ಉಂಟು. ಅಲ್ಲಿಗೆ ಹೋದ್ರೆ ನೀವು ಆಸ್ಪತ್ರೆಗೆ ಬರುವಾಗ ಒಂದು ನಂಬರ್ ಕೊಡ್ತಾರೆ ನೋಡಿ, ಹಾಸ್ಪಿಟಲ್ ನಂಬರ್ ಅಂತ. ಅದನ್ನು ತೋರಿಸಿದ್ರೆ ನಿಮಗೆ ಯಾವ ಫೈಲ್ ಬೇಕೋ ಅದನ್ನು ತೆಗೆದು ಕೊಡ್ತಾರೆ. ಆಗ್ಬೋದಮ್ಮ?
ಅಲ್ಲ ಡಾಕ್ಟ್ರೇ, ಅದು ಫೈಲ್ ಅಲ್ಲ, ಪೈಲ್ಸ್ ಕೆಳಗೆ ಆಗ್ತದಲ್ಲ, ಫೈಲ್ಸ್ ಅಂತ ಹೇಳ್ತಾರೆ.
ಇದು ಫೈಲ್ಸ್ ಅಲ್ಲ, ಫೈಲ್ಸ್ ಅಲ್ವಾ? ಏನಾಗಬೇಕಿತ್ತು ನಿಮಗೆ ಅದಕ್ಕೆ?
ಅದೇ ಡಾಕ್ಟ್ರೇ, ಅದು ತೆಗಿಬೇಕಿತ್ತು. ಎಷ್ಟು ಚಾರ್ಜ್ ಆಗ್ತದೆ?
ಒಂದು ಸರಿ ಸುಮಾರು 20-25 ಸಾವಿರ ಆಗ್ತದಮ್ಮ.
25 ಸಾವಿರನ? ಅಷ್ಟು ದುಬಾರಿಯಾ? ಕಮ್ಮಿಯಲ್ಲಿ ಆಗಲ್ವಾ ಡಾಕ್ಟ್ರೇ?
ಅಲ್ಲಮ್ಮ, ನಿಮಗೆ ಫೈಲ್ಸ್ ಆಪರೇಷನ್ ಮಾಡಬೇಕಿದ್ರೆ ಅನೆಸ್ಥೀಸಿಯಾ ಕೊಡಬೇಕು, ನೋವಾಗದ ಹಾಗೆ. ಅನೆಸ್ಥೀಸಿಯಾ ಕೊಡುವಾಗ ಅದರ ಖರ್ಚು, ಅದನ್ನು ಕೊಡುವವರು ಇನ್ನು ಬೇರೆ ಸ್ಪೆಷಲಿಸ್ಟು, ಅವರ ಚಾರ್ಜು, ಮತ್ತೆ ಆಪರೇಷನ್ ಥಿಯೇಟರಲ್ಲಿ ಮಾಡುವುದು ಅದರ ಚಾರ್ಜು, ಹಾಗೆ ನನ್ನ ಚಾರ್ಜು ಇರ್ತದಲ್ಲ. ಇದೆಲ್ಲ ಕೂಡಿ ಸರಿ ಸುಮಾರು 20-25 ಸಾವಿರ ಆಗ್ತದಮ್ಮ.
ಅದೆಲ್ಲ ಬೇಡ ಬಿಡಿ ಡಾಕ್ಟ್ರೇ, ಕಡಿಮೆಯಲ್ಲಿ ಮಾಡಿ.
ಹಾಗಾದ್ರೆ ಅನೆಸ್ಥೀಸಿಯಾ ಕೊಡೋದನ್ನೇ ಮಾಡೋಣವಾ? ಹೇಗೆ?
ಅದೇನು ಅದೆಂತ ಅನತೇಶ? ಅದೇನು ಡಾಕ್ಟ್ರೇ?
ಅದಮ್ಮ ಅನೆಸ್ಥೀಸಿಯಾ ಅಂದ್ರೆ ನೀವು ಕೇಳಿರ್ಬೋದಲ್ಲ, ಮತಿ ತಪ್ಪಿಸುವುದಂತ. ನಿಮ್ಗೀಗ ಫೈಲ್ಸ್ ಮಾಡುವಾಗ ನೋವಾಗೋದಿಲ್ವಾ? ಅದಾಗದ ಹಾಗೆ, ನೋವಾಗದ ಹಾಗೆ ಅನೆಸ್ಥೀಸಿಯಾ ಕೊಡ್ಬೇಕಾಗ್ತದೆ. ಅದಕ್ಕೆ ಬೇರೆ ಡಾಕ್ಟರ್, ನಾನಲ್ಲ ಅನೆಸ್ಥೀಸಿಯಾ ಕೊಡುವುದು. ಹಾಗೆಯೇ ಅದನ್ನು ಆಪರೇಷನ್ ಥಿಯೇಟರಲ್ಲಿ ಮಾಡಬೇಕು, ಇಲ್ಲದ್ರೆ ನಂಜಿ ಆಗ್ತದೆ ನೋಡಿ. ಹಾಗಾಗಿ ಅದನ್ನೆಲ್ಲ ಚಾರ್ಜ್ ಕೂಡಿಸುವಾಗ ಅಷ್ಟಾಗ್ತದಮ್ಮ. ಅದಕ್ಕಿಂತ ಕಡಿಮೆ ಆಗಲಿಕ್ಕೆ ಸಾಧ್ಯ ಇಲ್ಲ ಎಲ್ಲೂ.
ಓಹೋ, ಅಲ್ಲ ಡಾಕ್ಟ್ರೇ, ಕೆಲವರು ತುಂಬಾ ಕಮ್ಮಿಯಲ್ಲಿ ಮಾಡ್ತಾರಂತೆ. ಅದೇ ಬರೇ ಮದ್ದಿನಲ್ಲಿ ಮಾಡ್ತಾರಂತೆ. ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಬರ್ತದಲ್ಲ ನೋಡಿ, ಫೈಲ್ಸ್ ಕ್ಲಿನಿಕ್ ಅಂತ, ಬರೇ 4-5 ಸಾವಿರದಲ್ಲಿ ಆಗುತ್ತೆ ಅಂತೆ. ನೀವು 25 ಸಾವಿರ ಹೇಳ್ತೀರಲ್ಲ ಡಾಕ್ಟ್ರೆ?
ಆಯ್ತಮ್ಮ, ನಿಮ್ಗೆ ಕಡಿಮೆಯಲ್ಲೇ ಆಗ್ಬೇಕು, ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ನೋಡ್ಕೊಂಡು ಹೋಗ್ತೇನೆ ಅಂತಿದ್ರೆ ಹೋಗಿ ನೋಡಿ. ನಿಮ್ಗೆ ಒಳ್ಳೇದಾದ್ರೆ ನಂಗೇನು ನಷ್ಟ, ಮಾಡಿಸ್ಕೊಳ್ಳಿ.
ಆಯ್ತು ಡಾಕ್ಟ್ರೆ, ನಾನು ಬೇರೆ ಕಡೆಯಲ್ಲಿ ಆದ್ರೆ ನೋಡ್ತೇನೆ.
ಆಯ್ತು. ಈ ತಕರಾರು ಪೇಷಂಟ್ಗಳ ಜೊತೆ ಮಾತಾಡಿಯೇ ಸುಸ್ತಾಗ್ತದೆ. ನನ್ನ OT ಲಿಸ್ಟ್ ಇವತ್ತು ತುಂಬಾ ಉದ್ದ ಇತ್ತು. ನಾನೊಂದು ಊಟಕ್ಕೆ ಹೋಗಿ ಬರ್ತೇನೆ. ಹಲೋ
ಹಲೋ ಡಾಕ್ಟ್ರೇ, ನಾನು ಪ್ರಮೋದ.
ಓ, ಫೈಲ್ಸ್ ಪ್ರಮೋದ. ಏನಾಗ್ಬೇಕಿತ್ತಮ್ಮ? ಎಲ್ಲ ಹೇಗಾಯ್ತು ನಿಮ್ದೆಲ್ಲ? ಮತ್ತೆಲ್ಲ ಈಗ ಹುಷಾರಾಗಿದ್ದೀರಾ?
ಡಾಕ್ಟ್ರೇ, ತುಂಬಾ ನೋವು ಡಾಕ್ಟ್ರೆ, ತಡ್ಕೊಳ್ಳಿಕ್ಕೆ ಆಗೋದಿಲ್ಲ, ನಿಲ್ಲಕ್ಕೆ ಆಗೋಲ್ಲ, ಕುತ್ಕೊಳ್ಳಿಕ್ಕೆ ಆಗಲ್ಲ. ಹೋದೆ ಡಾಕ್ಟ್ರೆ, ಅಡ್ವರ್ಟೈಸ್ಮೆಂಟ್ ಅನ್ನು ನೋಡಿ ಹಾಳಾಗಿ ಹೋದೆ. ತುಂಬಾ 10-15 ಸಾವಿರ ಖರ್ಚು ಮಾಡಿದ್ರೆ ಏನೂ ಆಸೆ ಆಗಿಲ್ಲ. ಮೊದಲು ನೋವಿರ್ಲಿಲ್ಲ, ಈಗ ನೋವು ಬೇರೆ ಶುರುವಾಗಿದೆ ಡಾಕ್ಟ್ರೆ. ಏನಾದ್ರೂ ಮಾಡಿ ಅಲ್ಲ ಡಾಕ್ಟ್ರೆ?
ಅದು ಹಾಗೆ ಆಗುವುದು. ಸರಿಯಾಗಿ ನೀವು ಕೇಳಿಸ್ಕೊಳ್ಳಿಲ್ಲ, ಆಯ್ತು ಬಿಡಿ. ಈಗ ತೊಂದರೆ ಉಂಟಲ್ಲ, ಬನ್ನಿ ಆಪರೇಷನ್ ಮಾಡಿಸ್ಕೊಳ್ಳಿ. ಯಾವಾಗ ಬರ್ತೀರಿ? ದಾದಮ್ಮ ಆಸ್ಪತ್ರೆಗೆ ಹೋಗ್ತಾನೆ ಅಂತ ಬಿಗ್ ಬಜಾರ್ ಬರ್ತಿದ್ದಾರೆ ಈಗ. ಬೈ 1 and get 1 free. ಅದ್ರ ಈತೆ ತಗೊಂಡೆ ಸಾಮಾನು ತಗೊಂಡು ಒಂದು ಪ್ಯಾಂಟ್ ಒಂದು ಶರ್ಟ್ ತಿಕ್ಕೊಂಡು 25,000ಕ್ಕೆ ಒಂದು ಪೈಲ್ಸು ಒಂದು ಅಪೆಂಡಿಕ್ಸ್ ಹಾಗೆ ನಮ್ದೊಂದು ಟಾನ್ಸಿಲ್ ತೆಗೆದುಬಿಡಿ ಅಂತ ಹೇಳ್ಬಿಡ್ಬೋದು ನೀವು. ಒಳ್ಳೆ ಗಿರಾಕಿ ಅಮ್ಮ, ಇದೆಲ್ಲ ಆಗೋದಿಲ್ಲ, ನೀವು ಬನ್ನಿ ಮಾಡೋಣ, ಇಲ್ಲದಿದ್ರೆ ಬರ್ಚ್.
ಡಾಕ್ಟ್ರೆ ಕೂಡ ಒಂಜಿ ಸಂಶಯ ಡಾಕ್ಟರ್
ಇರ ಸಂಶಯನೇ
ದಾದೆ ಗೊತ್ತುಂಟು ಈರೆ ಮಲ್ಪುನದೆ ಡಾಕ್ಟ್ರೆ ಆಪರೇಷನ್
ಅನ್ನದು ಯಾನೆ
ಬೇತೆಲ್ಲ ಬರೇ ಇರತ್ತೆ
ಬೇರೆ ಮತ್ತೆ ತಪ್ಪ ಅನೆಸ್ಥೀಸಿಯಾ ಕೊಡ್ತುನಾಡು ಬೊಕ ನರ್ಸ್ನಾಡು ಬೇರೆ ಏರ್ಪಟ್ಟದು
ಅತ್ತ ಆಪರೇಷನ್ ಇರೋದು ಬೇಗ ಗೊತ್ತುಂಟು ಡಾಕ್ಟ್ರೆ ಮಸ್ತ್ ಕಡೆ ಪೂರ ಓದ್ದೆ ಈ ಪೈಲ್ಸ್ ಕೊಟ್ಟು ಕಿಡ್ನಿಲ ತೆತ್ತು ಕುಡಿಯೋದ
ಹೌದಾ ಅದಮ್ಮ ಕಿಡ್ನಿ ತೆಪ್ಪುನಿ ಅದ ಕೋದು ಬದನೆಕಾಯಿ ಕೊಯ್ಲೆಕ್ಕ
ಡಾಕ್ಟರ್ ಸಾರಿ ಡಾಕ್ಟರ್ ನೀವು ಹೇಳಿ ನಾನು ಬರ್ಪೆ ನಾನು ಎಲ್ಲೇನು ಬರ್ಪೆ ಡಾಕ್ಟರ್ ಭಯಂಕರ ಬೇನೆ ಡಾಕ್ಟರ್ ಬರ್ಪೆ ಥ್ಯಾಂಕ್ಸ್ ಮಸ್ತ್
ಆಂಡಮ್ಮ ಆಂಡ್ ಈ ಕಟ್ಟುವಾದ ರೋಗಿಗಳಿಗೆ ಪಾತೆರ್ದು ದಿನೋಲ್ಲ ನೀರು ಬರ್ತಾರೆ ಸಮಯ ಎಲ್ಲ ತಿಕ್ಕಂಡು ಎಂಕ್ಲ ಮಳೆ ಬರ್ತಾ ಇರ್ತದೆ ನಾನು ಪೈಲ್ಸ್
So hope you have all enjoyed reels ವೈದ್ಯ ಸುರುಳಿಗಳು. ಈಗ ಪಾತ್ರ ಪರಿಚಯ. ಮದುಮಗಳಾಗಿ ಡಾಕ್ಟರ್ ಸಂಚಿತಾ, ಮೈಕ್ರೋಬಯಾಲಜಿಸ್ಟ್, ಏಜೆಂಟ್ ಫಾರ್ ಮೆಡಿಕಲ್ ಸೈನ್ಸಸ್. ಮದುಮಗಳ ತಾಯಿಯಾಗಿ ಡಾಕ್ಟರ್ ವೀಣಾ ಭಗವಾನ್, ಗೈನಕಾಲಜಿಸ್ಟ್, ಏಜೆಂಟ್ ಫಾರ್ ಮೆಡಿಕಲ್ ಸೈನ್ಸಸ್. ಚರ್ಮರೋಗ ತಜ್ಞರಾಗಿ ನಾನೇ ಡಾಕ್ಟರ್ ಸರ್ಗ್ಯ, ಪೆಥಾಲಜಿಸ್ಟ್, ಏಜೆಂಟ್ ಫಾರ್ ಮೆಡಿಕಲ್ ಸೈನ್ಸಸ್. ಎರಡನೇ ಸುರುಳಿಯಲ್ಲಿ ಕಣ್ಣಿನ ವೈದ್ಯರಾಗಿ ಡಾಕ್ಟರ್ ಸುಮಲತಾ, ಅನೆಸ್ಥಿಸಿಯಾಲಜಿಸ್ಟ್, Shema, and Dr. Gayatri Bhatt as Ajji Purana, Dr. Praveen Jan as granddaughter, and ಮೂರನೇ ಸುರುಳಿಯಲ್ಲಿ ಶಸ್ತ್ರಚಿಕಿತ್ಸರಾಗಿ ಡಾಕ್ಟರ್ ಅಮೃತ ಭಂಡಾರಿ, ರೋಗಿಯಾಗಿ ಡಾಕ್ಟರ್ ಪ್ರಮೋದ, ಗೈನಕಾಲಜಿಸ್ಟ್, infertility specialist, Oasis Fertility, Agent of Medical Sciences, Mangalore.
Ladies and gentlemen, we've had the pleasure of witnessing unprecedented, exhilarating, mind-blowing performances by our own extremely talented IMA members. I think every person who has been involved in this cultural program deserves a huge round of applause.
Thank you.
Karnataka State. Thank you for gracing this occasion.
To introduce today's first speaker,
in craniofacial trauma, total temporomandibular joint replacement and facial asymmetry. He has over 20 years of experience in this field, and his areas of interest are oral surgeries, cleft palate surgeries, craniofacial traumas, facial asymmetry, TMJ disorders, and so on and so forth. He is also expertise in the management of oral cancers. Over to you, sir, Dr. Darnath Kaman.
Work we undertake in this particular field of maxillofacial surgery. Since maxillofacial surgery is a vast branch, it's an internationally recognized branch which takes 16 years to qualify in the master's program in the UK, and it takes 11 years in the US to qualify. It's a dual degree which is required in the States as well as in London, whereas in the Indian scenario, we acquire maxillofacial surgery over a period of 5 years, including the fellowships if the candidate is interested in. Today my talk would be on the spectrum of maxillofacial surgery. To be more specific, I would like to speak on a variety of procedures what we undertake in maxillofacial surgery. This is greetings from Mangalore KMC. And anomalies. When I speak about craniofacial anomalies, it's about treating children with Crouzon's and Epert's syndrome as well as varied areas of craniosynostosis. Of course, chronic facial pain disorder, where my colleague Gaurav is going to speak about, as well as temporomandibular joint disorders. My area of specialization is TMJ disorders, where we have specialized in temporomandibular joint replacements, like how you have hip and knee replacement. We also specialize in temporomandibular joint replacements. Many patients come to us with a chief complaint saying we have constant jaw pain, and when we investigate, we tend to realize if there is an impending tumor or there is an internal derangement or an osteoarthritis of the temporomandibular joint, which subsequently leads to chronic pain as well as resorption of the joints. These are smaller procedures what we undertake on an OPD basis. These are other procedures what we undertake on a regular basis. Non-healing ulcers over a period of 14 days. Patients come to us, we investigate, do the incisional biopsy, and then send it for histopathology and then follow it up with a surgical practice. Maxillofacial trauma is that branch which requires specialization. To understand maxillofacial trauma, as dentists we are blessed because we know the concept of occlusion. What is the concept of occlusion means? When you are sitting and listening to me at this particular time, you are in a static position. When I say static, your condyles or the epicondyle which is there in the skull base is in its best possible position, and your teeth are meeting each other. But when a patient comes to us with maxillofacial trauma, the first leading question what we ask the patient is, hallu ondu seri barutta? That means, are your teeth meeting each other? If the patient says, hallu ondu seri barodilla, that is the reason, that's an indicator to understand that there is a misalignment or a malalignment of teeth which leads to a fracture in the dentition. What popularly we would have studied as a Lefort fracture in our undergraduate days. This is the patient with frontal bone fracture. Both inner and outer tables involved, the CT scan showing the same. Next. Patient was taken up for surgery. I normally tend to do this with the neurosurgical team. One thing I need to tell at this stage is whatever cases you are seeing or whatever I am portraying is a part of the team effort. It's not a single man's journey through all these surgical practices. So these are the surgical practices. We raise a bicoronal flap. We do an extracorporeal fixation of the entire frontal bone and give back the facial aesthetics to the patient. Next. Next. So now you can see this patient's frontal forehead or the upper third of the facial skeleton, which was depressed, has been restored to its normal continuity. The next case is again a bare maul injury where patient came to us, and you can see the entire nasal septal avulsion. So we end up raising a bicoronal and fixing the skull base to the nasal bone, as well as sometimes you need to do a delayed reconstruction in these kind of cases because you need to understand that nose and the nasal septum has memory, so it tends to go back to its original position. It's in that instance you have to do a delayed reconstruction where we do a salvage first and then take the patient up for secondary procedures. Next. This is another case of an engineer by occupation who came with panfacial injury. When I say panfacial trauma, when more than 1/3 of the facial bones are involved, we call it as panfacial injuries. Every part of the face is broken into pieces. Now it is to assimilate and understand that it's like a jigsaw puzzle which you have to put back into position. So you need to have a plan in position, whether you want to work from the top to the bottom or from the bottom to the top. This is the immediate intraoperative picture, or when she was in the neuro ICU, which was taken there, and then the subsequent facial photographs. If you see the image at a very close range, she's still got a redundant enophthalmos which needs to be treated at these cases. Next. These are patients who have undergone maxillofacial trauma with fractures of the mandibular bone and possibly be going for surgical practice through extraoral approaches, putting up submandibular and parotid incisions where we approach the condyle in the skull base and do an open reduction and internal fixation. Probably yesteryears, the dentist or the surgeons would wire the jaws, but today the order of the day is the same principles what we follow from our orthopedic principles, that is open reduction and internal fixation of every facial fracture if it's the best thing to do so. Next. These are orbital floor fractures. Patients present to us with redundant double vision, or what popularly is known as diplopia. When patients come to us with constant diplopia which does not resolve over a period of 7 to 10 days, that means to say that there is an inferior rectus entrapment, and you take in your CT scans in a serial manner to understand if the orbital floor on the lateral side is showing you that the orbital floor is fractured and there is incarceration of muscles or the inferior rectus. We take up the patient for surgical practice and then reconstruct the orbital floor. You can see the entire orbital floor plate there, spawning the floor defect. This is a blind procedure because you need to understand that the plate should not extend beyond the 25 millimeter mark. So what I do is we do an intraoperative endoscopic reduction of these kind of fractures where you have the endoscope which is put through the maxillary sinus to see the posterior extent of the floor plate. Next, please. These are patients. The reason why I have not marked out the eyes is because if I close the eyes, or the identity needs to be taken care into, but I cannot show the exact extent of the deformity. If you see the child there, he's got a right orbital floor fracture. That is a classic feature of staring in the eye appearance. The right eye is not moving up. That means to say that the child has got a trapdoor fracture. So the child was taken up for surgery. In the center diagram, you can see the orbital floor defect reconstructed with an orbital floor or a mesh plate. All these are alloplastic titanium implants, but sometimes if the patient cannot afford, what I tend to do is, with evidence-based literature, we tend to take the septum or the conchal cartilage and reconstruct the floor based on the defect size. Next. Oral oncology. Head and neck oncology is most commonly done as a team approach. Possibly I do the reconstruction part, whereas the head and neck dissection is done by the oncosurgery team. Whereas a patient presented to us with well-differentiated squamous cell, and we entered doing a left neck dissection at a level 1, 2, and 3. Next, please. Salivary gland pathologies, again, an eye-opener with similar adenoid cystic carcinoma in the floor of the mouth, treated with wide local excision as well as reconstructed with a nasolabial flap. Next. Ranulars, I'm sure we understood this particular entity, transparent cystic swelling in the floor of the mouth, amenable for a simple enucleation or a marsupialization to understand if it doesn't want to recur again. So we suture the cystic contents to the floor of the mouth and make sure that there is considerable shrinkage of the tumor there. Next. Cystic tumors play an essential role in regular diagnostic aids when patients come to us and say that there is some amount of pus discharge coming out. And when we take a diagnostic X-ray, you see that there is a perforation of the mandible there. We end up enucleating the entire cyst. And nowadays, we don't use alloplastic bone from the market what is available. We use the patient's own blood to prepare what is called as platelet-rich fibrin, wherein the PRF has got a high potential for osteogenic take up. So the cells or the osteoblasts have a bridge to jump from one to another, and then we build up and you see nice bone formation there over a period of time. So PRF is here to stay. Next, please. This is another tumor of the mandible, aminoblastoma. We normally don't resect this, we take into consideration the patient's age, but nowadays, because of advances in science and technology, we're looking at a total joint replacement, but not all patients are the ones who require a TJR or a joint replacement. So affordability is another concern in these kind of patients. We need to look at that as well. Possibly 10 years ago, I would have done an enucleation, but since there is an extracapsular spread here, we went in for a resection and we reconstructed the entire mandible using a costochondral rib graft as a spacer so that we can go in and revisit again and put in a joint replacement there. Next slide, please. This is harvesting the graft from the rib and reconstructing the entire mandible with the rib in place. Next slide, please. That's the entire rib which has been used to reconstruct. So the rib is only a spacer, but if you use the rib in a child with the same diseased process, the rib has a potential to grow where we retain the costochondral junction, possibly to a 1 to 2 mm. So this plays an essential role in adult patients where it maintains that particular area, and then we can revisit back and go in for a joint replacement. Science and technology has taken a good comeback to us in this particular era, where we have used science and technology for our possible help. This is a young boy, 18 years old, who presented to us with aminoblastoma of the mandible. The father was a planter by occupation. We operated on this boy with a resection of the hemimandible, and we gave the possible rehabilitation using a free fibula, but the boy was not very much for the fibula to be taken from the leg. So the next option was a total joint replacement where we got it shipped from the US, Atlanta, Jacksonville, and we reconstructed the entire hemimandible with the total joint replacement system there, possibly the first of its kind in our own South Canara. We reconstructed the entire jaw that's made of pure titanium, and to incorporate bone into that particular area, we made in shafts so that bone from the iliac crest could be taken. Next. These are the planning stereolith models what we get from the US so that intraoperatively our time is saved and you can reconstruct the entire joint, giving back like to like and also maintaining the facial aesthetics. Next slide please. That's the post-operative profile after resection of the mandible, where the entire profile has been taken up by the systematic adaptation of the temporomandibular joint reconstruction. Next. That's the PA view mandible showing the joint replacement system in place. Next. Next. This is the lady who came to us with the aminoblastoma of the mandible. You can see that the entire tumor has gone into the skull base, involving the coronoid process as well as the periosteal breach has happened. Since being a girl, 19 years old, a joint replacement wouldn't be an only option. So what we planned to do was take a CT scan, send it across to the biomedical team, get, or what we call as mirror the left side to the right side. Next slide please. We mirrored the left side mandible, which was normal, to the abnormal side. The yellow one was the tumorous side. So we mirrored the same thing onto the right side. Next. Next. And this is how we plan for a free fibula. We take the STL model, we get the model of the fibula from the leg. Deficit is calculated based by keeping the bone on the mandible. Next slide please. And then the fibula is harvested on table. Once we resected the jaw, we take the prototype, place the fibula, and then attach the fibula to the reconstruction plate. Next slide. That's the post-operative picture, and that's the CT scan which shows you the microvascular anastomosis there along with the reconstruction plate as well as the free fibula there along with the skin paddle intraorally. The only issues with this is rejection of the free fibula because you are anastomosing it in the neck. So constant monitoring by the plastic team as well as from the parent unit is a must when we plan these kind of high-end procedures. That's the post-operative profile of the patient post-operatively. There she is with the replaced mandible, like to like. Next slide please. Hemifacial microsomia is another entity which has been very difficult for us to treat because there is some amount of soft tissue hypertrophy, it's hypertrophy. this boy had a redundant condyle which was never there, possibly a type 3 Bruzanski. Next slide please. And he had an occlusal cant there which was coming downwards. So these patients need to be systematically managed in correcting their occlusal cant as well. Hence the cant was corrected. Next slide please. That's the CT scan showing the absence of the condyle and the coronoid. That's why the maxilla follows the mandible over a period of time. Next. And these are the stereolith models what I plan before the surgical practice outside the theatre so that my surgical time is saved. We manufactured the joint in India this time. We didn't go into the US to get these joints. This is a Make in India project where the joints were manufactured in India, which if I had got it done in the US would have costed me not less than 16 lakhs. When we did it in India, it came up to possibly 3 lakhs. And that's the surgical approach. We go into the skull base, remove the redundant tissues which has been occupying the middle glenoid fossa, make a possible rent there. Next slide. Next. That's the stump which ends there. That's the classic preauricular approach, or popularly called as the Bailey's approach. The same approach if taken downwards for parotid gland tumors as well. Next slide. That's the costochondral rib which was also taken. Next slide. Then the osteotomies in the mandible to correct the cant of occlusion, where the maxilla was canting downwards by doing osteotomies. Next slide. And that's the joint in place where the patient still requires some amount of augmentation of the lateral face by fat transfer. Next. If you see the entire mandibular occlusion and the occlusion is restored, but you can still see the soft tissue deficit on the right side which needs to be managed via full thickness or sequential fat transposition there in that particular area. Next slide. These are the post-operative x-rays on the lateral view showing the joints in place. Next. These are the Lifford osteotomy, plates and screws being held in place. Next. The same thing to follow. Carry on. This is a patient who had a missing lower jaw or absent mandible. If you see, the entire chin is gone back. There is no chin, there is no mandible. The patient was from Davangere. He presented with obstructive sleep apnea. So the only issue was to manage that obstructive sleep apnea first. We got a polysomnography to understand what kind of apnea he was suffering from, whether it's mild, moderate or severe. And what I planned was distraction osteogenesis using the principles of orthopedicians. You distract the bone sequentially over a period of time. So what I did was we got this STL model done, did the surgery on the STL model, made the stents so that it could become easier for me. Next slide please. Planned the distraction movements outside. These distractors are from the US, which I had got after my training. They gave it as a compliment. So I got this along with me. I use it in patients who cannot afford so that we can give a quality of life to these kind of patients. That's the amount of distraction. If you see here, the amount of mandibular movement is around 16 millimeters downwards and 14 millimeters anteriorly. So that is going to cure this obstructive sleep apnea. Next slide. And this is the geometric evaluation of the deficiency. A little bit of mathematics involved. Next slide. These are the surgical practices of putting the distractor in place. Next slide please. These are the different phases of treatment. That was how he came to us before distraction. During the distraction, and last stage was post-distraction. You see the amount of fat he put on after the jaw was advanced. Now the challenge was to open his mouth since he also had ankylosis, where the mandible had fused to the skull base. So I took him up, next slide please. I took him up for a bilateral joint replacement. Next slide. And that's the STL model where I do the joint replacements on these models, assess how much of mouth opening is achievable. Next slide. And that's the final clinical image you see there. Nice big mouth opening of 40 millimeters. And that's his facial appearance from where he's come, and now his mandible is advanced anteriorly. Next slide. These are his different phases of facial transformation from there to there. It was all over a period of 2.5 years. Next slide. And these are his post-operative x-rays which were taken sequentially. Next slide. Next slide. This is a girl who came with a severe malocclusion or differentiating bite, and the entire face turned towards the left side. So the challenge was to relocate the entire face to the center. For me it is easy to say, but all these surgeries are only possible if the patient is compliant. No surgeries are without complications. I stand before you showing my pictures, but I've undergone my share of complications. It's very difficult from the patient's perspective and from the surgeon's perspective. To be honest, sometimes we feel, do I need to do all this? Going through the risk, going through the family tensions. We are the torch bearers, but sometimes you feel, is it really required? So this patient was again taken up for the surgical practice, same STL models. This practice of doing these asymmetrical cases of the face also involves the orthodontist. An orthodontist is one who puts in braces, in simple terminologies, to align the teeth. But here, the issue is not aligning the teeth. The issue is aligning the teeth and aligning the jaws. So you need to do both the things at the same time. Next slide, please. And these are surgeries what we undertake inside the mouth. That's called the sagittal split osteotomy and the Lefort osteotomy. Next slide. These are intraoperative pictures, and I also advanced her chin because she was very concerned about her facial appearance. She said, I want my chin to be very prominent, which was deviating towards the left-hand side. Next slide, please. And that's the facial. Click again. That's her facial appearance in the amount of... It was a very difficult task for me to get that because she had her share of complications in the form of unfavorable fractures. When I say unfavorable fractures, these are complications which arise on the table. And there was a little bit of avascular necrosis as well of the mandible, which was managed by giving medications as well as hyperbaric oxygen therapy. Next slide, please. Next slide. Next slide. These are patients who come with, again, condylar hyperplasias, where the entire jaw is turned towards the left. If a patient presents to you in your practice where the entire jaw is deviating considerably over a period of time, that means to say that the growth center is still active in spite of being at the age of 19 to 21. That means the condyle, which is the growth center, is still active. In these kind of patients, what we do is, in KMC, we get a SPECT scanning done. And then we assess the amount of activity. Next slide, please. We assess the amount of activity from the right to the left. If the difference is more than 15%, we understand that there is an active growth which is happening over the time, over puberty as well, in spite of being 19, 21 growth being complete. Hence, we go in for what is called as condylectomy. Next slide, please. We go in and do these virtual surgical plannings. This, I don't do this. You have a separate set of biomedical engineers. We send in the CT scans to them. They plan the surgery with us, not that they do the cuts. I tell them what is to be done. They plan the surgery. Once they plan the surgery, we see the final result, how the patient is going to look on the computer. And these are the cutting guides to say that you cannot afford to cut the inferior alveolar nerve or the mandibular nerve which supplies sensations to your lower lip. So once we transect that excess amount of mandible, then you can go in and do the surgery with these guides. Next slide, please. So I did the condylectomy, did the differential Lefort osteotomy as well. Next slide. And then resected the excess of the mandible, all from the intraoral approach or inside the mouth, because the girl never wanted a scar. She was due for her marriage. Next slide. These are x-rays of the same patient. You see the entire curvature of the mandible deviated towards the left side. Post-surgery, the entire mandible is in the centric relation or in the central position. Next slide. That's the transformation. Click again, please. And that's her without a chin surgery. The chin has come back to the normal. We normally keep the chin as in the second stage, because if I do it in the first stage, it's going to be an overkill. So we normally keep it there if she requires a second stage surgery. Next slide. Next slide. These are babies with multiple sutural craniosynostosis. There you can see the exophthalmos because there is underdevelopment in the floor of the mouth, possibly an Epert's or a Treacher Collins. This is done with my neurosurgery colleagues. It's not a single man approach. We plan this again with virtual surgical planning, and this is trigonocephaly plus mild anterior plagiocephaly and synostosis of the metopic, coronal and anterior fontanelle. So these are the planning maneuvers what is undertaken with the surgeons in place along with the biomedical engineers. Next slide. Next slide. That's raising the flap, the pericranial flap, then planning the osteotomies, burr holes with the Hudson brace. Next slide. And then raising the frontal bone as well as the parietal band to understand which which part of bone goes where. Basically, it's a jigsaw puzzle when you handle children with craniosynostosis. You need to understand that one portion of the bone needs to be elevated, the other portion needs to be depressed. So you're creating the fractures there in these children so that they have that nice frontal bossing is gone, and you can give a nice frontal fall to these kind of children. Next slide. Next. And this is a child who came from Shimoga. If you see there, he doesn't have a forehead on the left side, it's flat there. So it's a plagiocephaly on the left side. I do these geometric maneuvers where I sit and plan, measure the defect on the STL model, which is given by the biomedical engineers. We plan the amount of measurement, and you see how much of movement has to be taken into consideration when we plan these cases. Next. And this is the affected side, that's the other side. Next. And then I take the pencil and mark, and once I mark with the pencil the abnormal and the normal side, we do what is called as an interchange or interpositioning of the frontal flaps. Once that is done, automatically the entire forehead on the redundant side or the affected side comes back to normalcy. Next slide. That's on the table when you're raising the frontal bone and separating it from the dura. Next. That's the extracorporeal breaking to give that nice frontal curvature there. You can see the frontal bandu being raised. And then once we break it, we fix it with 1,0-proline or a mini plate. Those were the days where we used to use titanium mini plates. But today when you look back, we have resorbable systems because you don't want to subject the child to have a titanium implant on the forehead or in the cranial region, because that can lead to what is called as internalization. Next. And that's the child. You see now the child has got a nice forehead and the eyes are within the cover of the forehead. Next. And finally, this is one patient who came to me from the US. Never had a lower jaw mandible. You see the neck chin throat angle is what we call this. The child had a severe receding jaw with obstructive sleep apnea there. If you look into literature from the orthopedic side as well as from the maxillofacial side, doing a joint replacements in patients who are skeletally immature is a contraindication. But this child was 9 years when he came to me. He was operated 7 times for the same surgical practice using costochondral ribs, distraction osteogenesis. So what we planned was a total joint replacement for this patient. And this is the planning maneuvers what we get from the States. They produce and they provide us with the final mandibular movement of how much the mandible is going to come forwards by. Next. That's the child post-surgery. The entire lower jaw has come forwards. Believe me, this child had a variation in the facial nerve anatomy. I'm being very honest. We operated on this child, but post-operatively I had bilateral facial nerve paralysis. The mother was surprised, but the mother was willing to travel that extra mile, and she said, I'm sure it's going to improve. Back in my heart, I knew that it's going to improve, because when we do these surgeries, we do not use cauteries, we do not use monopolars, we use only bipolars. So all these injuries were possibly a retraction kind of injuries. And this child had the joint replacement done there. That's the mandible, which was totally redundant. So if I had to do the same procedure done previously, I would have chopped off the mandible even more, and this mandible would have rotated clockwise backwards, causing severe sleep apnea. Next. These are the CT scans. Since the child was diagnosed as MRSA positive, I'm sure Dr. Chakrapani is here, he would remember the case. Thank you, sir. You have been with me and traveled with me through this case. I should be thankful to sir. We treated him for his MRSA, and we also treated him intraoperatively with these vancomycin beads so that there would not be a graft versus host reaction. So these are vancomycin beads, what you saw on the CT. This is normally used for most of my patients to prevent a surgical site infection, because if procedure goes beyond 8 hours, I'm sure we all know from the American Surgical Association classification that it's prone for a possibility of an infection. Next slide, please. That's the post-operative picture. You can see the entire mandible rotated downwards and forwards with the prominence of the chin. And with this procedure, the child had decreased obstructive sleep apnea. His mouth opening improved from 0 to 27. And now the patient is put on weight. And possibly
he will require a revisit of these joints at the age of 19 years. We will have to revisit and put in new joints when he grows at 19 years. For giving me an opportunity.
Most unique skill sets which we observe in Mangalore today. Dr. Gaurav Gomez has completed his entire education in some of the most elite institutions in the world. MBBS from St. John's, MD from CMC Vellore, and postdoctoral fellowships from NIMANS, AIMS, and the Indian Association of Palliative Care. Right now, he is working as consultant, pain medicine and neuro rehabilitation at KMG Hospital, Jyoti or Ambedkar Circle. A pleasure to welcome you, sir. Thank you.
Tough task for me. Actually, one of the first people I met was Dr. Abhay, and in his OPD there were all these 3D printed models, and I was quite impressed. And mine is a different department. It is relatively new in Mangalore. There are very few of us around, and I give two services, basically pain medicine and neuro rehabilitation, which I'll explain. A part of pain medicine for today, but I'll have a slide which will give the rest of it also, just I'll explain at the end. So, going to the topic, sympathetic ganglion block. When I joined my fellowship in AIMS, I had no idea about this sympathetic chain and the anatomy and what its function was, but it was very interesting when I was there. So the introduction, sympathetic blocks have been known since the Second World War, where they have shown their utility in treating cases of causalgia. They used to call it causalgia at that time. Now it's called CRPS, complex regional pain syndrome. So the nervous system is divided into central and peripheral, just running through this. And the peripheral has autonomic and somatic. Autonomic has sympathetic and parasympathetic. Overview, parasympathetics puts you to sleep. I hope that doesn't happen to you all today. And sympathetics cause fight and flight. There are various roles of this, but sympathetics have basically three things. One is the vasomotor function. The second is pseudomotor, and the third is pilomotor. And a lot of the features of CRPS is a combination of these. So the sympathetic chain has 22 ganglia which run along the spine. This is the anatomical picture of it. So it starts in the cervical region, I'll just show you on the left side. Goes along the vertebra like this, anterolateral, and they end in the sacrococcygeal ligament. So there are multiple ganglion along it, and all are connected by a chain. And this chain lies on the side and has grey rami communicants and white rami communicants. And the interesting thing which I learned was, initially I was wondering which dermatome supplies the visceral organs of the body. And there isn't any dermatome because dermatome supplies the skin. So what supplies the visceral organs of the body? It's mainly the sympathetic system. The pain from these organs is via the sympathetic system. So from the visceral organs, it goes through the various ganglion and the plexus, sympathetic plexus goes into this chain and is non-dermatomal. So it can come from above, can come from below, and eventually it goes into the spinal cord through the white rami communicants. Somatic nerves go directly into the periphery. And this is the effect on the vessels. So there is a tonic activity of the sympathetic system which maintains the tone of the vessels. And when there is increase in this tone, it causes vasoconstriction. Also, the sympathetic system has a function in inflammation. It causes a lot of inflammatory changes and increases pain in the nerve endings. And blocking this, therefore, reduces the pain and increases the blood circulation. So we use it mainly for two broad categories: sympathetically mediated pain and vascular insufficiency and pain related with such stuff like claudication. So sympathetically mediated pain is like complex regional pain syndrome, also known as reflex sympathetic dystrophy, neuropathic pain, post-herpetic neuralgia, including acute herpetic pain is also a very good indication for this. Phantom limb pain, visceral pains, it's a very good indication, especially in cancer. Raynaud's disease, peripheral vascular disease, frostbite, and arterial embolism. Now, frostbite, even I was thinking, who gets frostbite in the Indian subcontinent? There are patients like, we came across one spinal cord injury patient who somebody told him to get some sensation back, you put ice on the legs. So he ended up putting ice. Some people have been told to put hot water and they've ended up getting burns because they're not aware and they get these issues. And there are a lot of reports of the same indications. So now we are ready to give these injections, but we need to be aware of what are the indications. Now most of these injections, it's a little query whether it will work or not little, but about 50-50 chance. But the only way to make sure is giving a diagnostic block. If you give a diagnostic block with a local anesthetic, then if the patient gets immediate relief, you know that a longer procedure will work. Then you can go in for a more definitive procedure. Contraindications are general indications, along with that even bleeding diathesis. Precautions, it's better to have some sort of imaging and consent, and there are side effects which are specific for each of these. I'll give you an example. So now, where do we give these injections? We have different ganglia and plexuses for different indications, and we can inject at practically any of these. Common ones being stellate ganglion for various indications, including atypical head, face pain, for CRPS of the upper limb, for PDD of the upper limb, for Raynaud's of the upper limb. So basically upper limb and head and neck issues, including malignant pains of the head. This is the thoracic chain for visceral pain from the chest, like cancer-related pain or angina. In fact, stellate ganglion block have also been used for arrhythmias because it supplies the heart also. Now, celiac plexus is for pain related to visceral organs of the upper GI tract. Then we have the lumbar sympathetic ganglion, which is used for lower extremity pain and to some extent renal issues. Then superior hypogastric for OB/GYN and genital issues related to pain, cancers of the genital region or the bladder, lower urogenital tract causing pain. And ganglion impa for cases again with perineal pain and also for coccydynia. So in this video, which again I don't think will work, I was just going to show you the anatomy of where the celiac plexus is. So it is just where the celiac artery comes out, the plexus around that is the celiac plexus. We have superior hypogastric plexus, all that, and over here, we have the superior mesenteric ganglion, inferior mesenteric ganglion, and over here we have the superior hypogastric plexus, which is blocked for urogenital issues. This is the stellate ganglion block, and the importance is that there are a lot of vital structures around. You have the brachial plexus, and it's done usually at C7-T1 region. It's located there. It's the fusion of the lower cervical and the upper thoracic ganglion, so sympathetic ganglion together, and it's about 1 inch in size. We have the vertebral artery, and if vasospasm occurs or you put a particulate injection in that, it can cause a stroke. Other blood vessels, and importantly, the lung, because the pleura, especially in some thin patients, it rises quite high. And by T1, it is already just decided. So here we see the location. It's just about there. You have the lung and all these vessels and the brachial plexus next to it. So now, how do we give these injections? You can give it either landmark guided, which it's getting out of practice now, or imaging guided. So you can have fluoroscopy, X-ray guided, or ultrasound guided, and each has its pros and cons. So I use fluoroscopy or ultrasound guided guidance for my injections, and the common complications of this are relatively small, like hoarseness. Horner syndrome is almost in all patients, but it does not cause much of an issue, and they can get pneumothorax, and therefore bilateral injection is not given because it can, if a patient has pneumothorax or the other side you end up blocking the phrenic nerve, patient can have dyspnea. So the benefits of ultrasound which I commonly use our accuracy, you can see the blood vessel, you can see the needle going in real time, you can see if the plane you are in, and you can see the drug being injected. And the effects have been shown to increase blood flow, the resistance index of vessels has been shown to decrease, and the temperature of the limb has been shown to increase. We used to use it regularly for Raynaud's phenomenon in AIMS, and we used to use plethysmography, and even the waves would improve immediately after the injection. It has also been used in a case-by-case basis for pulmonary embolism, bilateral stellate ganglion block. Now for the lower limb, you give this lumbar sympathetic ganglion block, which is at L2, L3 and L4 level. Bilateral blocks are usually not given because it causes hypotension, and the volume of the block is, the dose of the local anesthetic is quite high, unless you're doing neurolysis. So this is the positioning again, like I had shown you. This is medial and anterior, this is lateral and posterior, the discs, and the sympathetic chain runs here, and these are the ganglia, which we try to block. So this is a block procedure. Patient is prone, and you put a needle, hit the body of the vertebra, change the position, go past the body and give the injection. Be aware of the various structures around it. So this is the fluoroscopy guided, some of the images. And ultrasonically it also can be done, though it is a deep structure, so it's a little, depends on the weight of the patient, how clear images we get. And we can see the injected being given. Stellate ganglion block has been used in vascular compromise, in torsades point, in for children. So it has also been used in children. We used to give it regularly for children over there using a 26 gauge long needle, and they had immediate relief. I'll show you a couple of videos of the children and what they report. Complex regional pain syndrome, post-herpetic itching in children again, and bilateral, like I mentioned, has its flaws. It's also been used in case reports about burning mouth syndrome and refractory ventricular arrhythmias. Our boss over there mentioned that when he was a student, they were called to the ICU every now and because patient had arrhythmias, they were told to give these injections, and they would give one side, wait for a while, and then give the other side. It's also been used for migraine, and there are other blocks which have been used for cluster headache as well. Again, for vascular insufficiency, this is in adult for urgent refractory ventricular arrhythmias, and digital ischemia, which has been due to sepsis. But ultrasound gives a lot of safety to this. So there are various types of blocks. Sympathectomy can be done chemically or using radiofrequency, and this prolongs the effect of the procedure. Again, videos will not play, I thought it would, but the first child reports 70% improvement in the pain after serial blocks. The second child, actually you can see the digits are atrophied, and she also mentions that she had blueness till the first interphalangeal joint, but after the serial blocks, the pain has reduced and the blueness has reduced. So pain management in KMC, what I offer is not limited to this. We also have nerve blocks for other chronic pain conditions, trigeminal neuralgias, various neuralgias, post-operative pain, joint pains, arthritis. Many patients who do not want surgery or are not fit for surgery, nerve injections or joint injections can be offered to them. Spasticity, nerve blocks can be given, and intra-articular joint blocks also I do worked. So the diagnosis was only by history and clinical examination. At the end of the history and clinical examination, I had a suspicion, gave a diagnostic block, and the patient had immediate relief. It was a syndrome called ACNIS, anterior cutaneous nerve entrapment syndrome. Celiac plexus around the celiac artery, and that is the superior hypogastric plexus. This can be done ultrasound guided or fluoroscopy guided. Different structures around this. You can see so many arteries. The vertebral arteries in blue, very close to this, and the pleura, which is actually, it comes even higher in some patients. Brachial plexus here, phrenic nerve also is here. Now it's very difficult to reverse this. So sooner the better. Neuro rehabilitation help out with issues like spasticity, pain, what splints, what is their potential from pain, and as it gets chronic, more chronic, just waiting for this to start. As it gets more chronic, when I was in CMC, we had 120 beds, IP beds for our department, but in Karnataka it has not yet been. A hypogastric plexus block. We used to use it for even MRK syndrome, but the cases that have a difference, but not so much for MRK syndrome. And the first thoracic, this is the stellate ganglia. And this is a chain which has various ganglia, and the chain.
Mangalore to celebrate the lifetime of service and accomplishments of our honored guests, honored members who are being felicitated here today, namely Dr. M.C. Suvarna, Dr. Denzel Pinto, Dr. J.N. Bhatt, and Dr. Vassalakam. We will also be felicitating the newly appointed Dean of KMC Mangalore.
So, without any further delay, we request the President and Secretary of IMA Mangalore to kindly escort the dignitaries to the dais. We request the guest of honor, Mr. M. Shantaram Shetty, Director, Tejaswini Hospital, and Dr. B. Unnikrishnan, Dean, KMC Mangalore, to kindly take their place on the dais. Blessings of the divine, and through the honors, with citing of the IMA prayer, I call upon Dr. Veena Bhagwan.
May everyone of us see to it that nobody suffers from any pain or sorrow. I do not ask for crowd, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. Thank you.
ಕೋಶಾಧಿಕಾರಿ ಡಾಕ್ಟರ್ ಜಿ.ಕೆ. ಭಟ್, ಕಾರ್ಯದರ್ಶಿ ಡಾಕ್ಟರ್ ಸದಾನಂದ ಪೂಜಾರಿ ಹಾಗೂ ನಮ್ಮ IMA ಟ್ರಸ್ಟಿನ ಮುಖ್ಯಸ್ಥರಾದಂತಹ ಡಾಕ್ಟರ್ ದಿವಾಕರ್ ರಾವ್, ಆಮೇಲೆ ಈ ವೇದಿಕೆಯ ಮುಂದೆ ಆಸೀನರಾಗಿರುವಂತಹ ನಮ್ಮ ಎಲ್ಲ IMA ಸದಸ್ಯರೇ ಹಾಗೂ ಅವರ ಮನೆಯವರೇ, ಅತಿಥಿ ಅಭ್ಯಾಗತರೇ, ಮಾಧ್ಯಮ ವರ್ಗದವರು, ಮಾಧ್ಯಮ ಮಿತ್ರರೇ, ನಿಮಗೆಲ್ಲರಿಗೂ ಕೂಡ ನಾನು ಶುಭ ಸಂಜೆಯನ್ನು ಹಾರೈಸ್ತಾ ಇದ್ದೇನೆ. ವೈದ್ಯರ ದಿನಾಚರಣೆ ನಾವು ಜುಲೈ 1ಕ್ಕೆ ಮಾಡಬೇಕಿತ್ತು, ಆದರೆ ಇವತ್ತು ಆದಿತ್ಯವಾರ ತುಂಬ ಜನ ಇದರಲ್ಲಿ ಪಾಲ್ಗೊಳ್ಬೋದೆಂಬಂಥ ಒಂದು ಇರಾದೆಯಿಂದ ನಾವು ಇಂದು ಇದನ್ನು ನಿಗದಿಪಡಿಸಿದ್ದೇವೆ. ಡಾಕ್ಟರ್ ಶಾಂತಾರಾಮ್ ಶೆಟ್ಟರೆ ಎಲ್ಲವೂ ರಾಜಕಾರಣಿಯು, ಶೈಕ್ಷಣಿಕ ತಜ್ಞನು, ಎಲ್ಲವೂ ಆಗಿ ನಮ್ಮನ್ನು ಹೊಂದಿಸಿಕೊಂಡು ಹೋಗಬೇಕು ಅಂತ ಮೊದಲಿಗೆ ಕಳಕಳಿಯಿಂದ ಪ್ರಾರ್ಥಿಸ್ತಾ ಇದ್ದೇನೆ. ಡಾಕ್ಟರ್ ಶಾಂತಾರಾಮ್ ಶೆಟ್ಟರು ಗುರುಗಳ ಗುರು. ನಮ್ಮ ಇಲ್ಲಿ ಹೆಚ್ಚಿನ ಜನರಿಗೆ ಅವರು ಗುರುಗಳೇ. ಈಗ ರಾಮಚಂದ್ರ ಕಾಮತ್ ಹೇಳಿದ್ರು, ಅವರಿಗೆ 3ನೇ ಪೀಳಿಗೆ ಸ್ಟಾರ್ಟ್ ಆಗಿದೆ, ಗುರುವಿನ ಅವರು ಒಂದು ಸ್ಟೇಜಿಗೆ ಹೋಗಿದ್ದಾರೆ ಅಂತ ಹೇಳಿದ್ರೆ 3 ತಲೆಮಾರಿನಿಂದ ಅವರಿಂದ ಕಲಿತವರು ಇದ್ದಾರಂತೆ, ಈಗ ಕಲಿತಾ ಇದ್ದಾರೆ. ಅದೊಂದು ಬಹಳ ನಮಗೆ ಸಂತೋಷದ ವಿಷಯ. ಆಮೇಲೆ ಡಾಕ್ಟರ್ ಶಾಂತಾರಾಮ್ ಶೆಟ್ಟರು ಅವರ ವಿದ್ಯಾರ್ಥಿಗಳ ತರಬೇತಿ ಮಾಡೋದ್ರಲ್ಲಿ ಎಷ್ಟು ಅವರಿಗೆ ಒಂದು ಕಠಿಣ ಪರಿಶ್ರಮ ಅವರು ತಗೊಳ್ತಾರೆ ಅಂತ ಹೇಳಿದರೆ ನಮಗೆಲ್ಲ ಗೊತ್ತಿದ್ದಂಥ ವಿಷಯ. ಅಷ್ಟು ಮಾತ್ರ ಅಲ್ಲ, ಅದೇ ರೀತಿಯಲ್ಲಿ ರೋಗಿಗಳನ್ನು ಚಿಕಿತ್ಸೆ ಮಾಡೋ ಕ್ರಮದಲ್ಲೂ ಕೂಡ ಎಲ್ಲದಕ್ಕಿಂತ ಅಂತ ಹೇಳಿದ್ರೆ ಅವರ ನಗು, ಯಾವ ಹೊತ್ತಿಗೆ ಹೋಗಲಿ, ಯಾವ ಹೊತ್ತಿಗೆ ನೋಡಿ ಅವರ ಆ ನಗು, ಆ ಒಂದು ಮಂದಹಾಸ ಯಾರನ್ನು ಕೂಡ ಮಂತ್ರಮುಗ್ಧರನ್ನಾಗಿ ಮಾಡುವುದರಲ್ಲಿ ಸಂದೇಹ ಇಲ್ಲ. ಅಷ್ಟು ಮಾತ್ರ ಅಲ್ಲ, ಇಲ್ಲಿ ಅನೇಕ ನಾವು MBBS ಮಾಡುವಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಅವರ ಸ್ಟೂಡೆಂಟ್ ಆಗಿದ್ದೆ. ಆಮೇಲೆ ಇಲ್ಲಿ ಅದಷ್ಟು ಅವರಿಂದ ತರಬೇತಿ ಹೊಂದಿದಂತಹ ಎಲುಬು ಹಾಗೂ ಕೀಲು ತಜ್ಞರಿದ್ದಾರೆ. ಅದು ಅಲ್ಲದೆ ಅವರೇ ಒಂದು ಸ್ವಂತವಾಗಿ ತೇಜಸ್ವಿನಿ ಆಸ್ಪತ್ರೆಯನ್ನು ನಡೆಸ್ತಾ ಇದ್ದಾರೆ. ಮೇಲಾಗಿ ಅವರು ಉತ್ತಮವಾದ ವಾಗ್ಮಿ. ಅವರು ಒಂದು ಮಾತಾಡಲಿಕ್ಕೆ ಶುರು ಮಾಡಿದರೆ ಮತ್ತೆ ಅದರಲ್ಲಿ ಏನು ನಾವು ನಗಾಡಬೇಕು, ಸಂತೋಷವಿರಬೇಕು ಅಂತ ವಾಕ್ಚಾತುರ್ಯ ಅವರಲ್ಲಿದೆ. ಅಷ್ಟು ಮಾತ್ರ ಅಲ್ಲ, ಅವರು ಸುಮ್ಮನೆ ಕೂತ್ಕೊಳ್ಳುವ ಜನ ಅಲ್ಲ. ಯಾಕಂತ ಹೇಳಿದ್ರೆ ಕೋವಿಡ್ ಸಮಯದಲ್ಲಿ ನಾವೆಲ್ಲ ಬಹುಶಃ ನಮ್ಮ ಕ್ಲಿನಿಕ್ಗೆಲ್ಲ ಹೋಗದೆ ನಾವು ಮನೆಯಲ್ಲಿ ರೆಸ್ಟ್ ಮಾಡೋದು ಅಥವಾ ಏನಾದ್ರು ಮಾಡ್ತಿದ್ದಿರ್ಬೋದು. ಆದರೆ ಅಂಥ ಸಂದರ್ಭದಲ್ಲಿ ಅವರು 4 ಬುಕ್ ಬರೆದಿದ್ದಾರೆ, 4 ಪುಸ್ತಕಗಳನ್ನು ಬರೆದಿದ್ದಾರೆ. ಅದರಲ್ಲಿ ಮುಖ್ಯವಾಗಿ ಯೋಗದ ಬಗ್ಗೆ, ಇನ್ನೊಂದು ವೈದ್ಯರ ನೀತಿಶಾಸ್ತ್ರ ಇದನ್ನು ಬರೆದಿದ್ದಾರೆ. ಆ ಬುಕ್ ಎಲ್ಲ ಲಭ್ಯ ಇದೆ, ಎಲ್ಲ ಸಾಹಿತ್ಯ ಕೇಂದ್ರಗಳಲ್ಲಿ, ಬುಕ್ ಸ್ಟಾಲ್ಗಳಲ್ಲಿ ಲಭ್ಯ ಇದೆ. ಅಂತಹ ಗುರುಗಳ ಗುರು ನಮ್ಮ ಶಾಂತರಾಮ್ ಶೆಟ್ಟರು ನಮಗೆ ಬಂದಿದ್ದಾರೆ, ನಮ್ಮನ್ನು ಹರಿಸಲಿಕ್ಕಿದ್ದಾರೆ. ಅವರಿಗೆ ನಾನು ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ತುಂಬ ಹೃದಯದಿಂದ ಸಾಧಿಸ್ತಾ ಇದ್ದೇನೆ. When Dr. Sadanand Pujari went and met him for getting an MU library in connection, because recently they got DNB seats at the Venlock Hospital. So for the reading facility, they wanted a library attachment. So when he met Dr. Unni Krishna, he was so happy and he welcomed him. So that shows his simplicity and generosity, and he readily agreed that we will do so. And moreover, he has become a new member of our IMA Mangalore. So he's a recent addition. So we have such a great personality with us as guest of honor. So on behalf of myself and all of us here, I welcome you for this unique evening. ಸಹೋದ್ಯೋಗಿಗಳು, ಮಿತ್ರರು, ಡಾಕ್ಟರ್ ಸದಾನಂದ ಪೂಜಾರಿ, ಡಾಕ್ಟರ್ ಅನ್ಯಯ್ ಕುಲಾಲ್ ಅವರು. ಅನ್ಯಯ್ ಕುಲಾಲ್ ತುಂಬ ಹರಸಾಹಸ ಮಾಡಿದ್ದಾರೆ. ಈ ನಮ್ಮ ಮಿನಿಸ್ಟ್ರನ್ನು ಬರಲೇಬೇಕು ಈ ಸರ್ತಿ ಅಂತ ಹೇಳಿ ಅವರು ಮಾಡಿದ ಸಾಹಸ ಕೇಳಿದರೆ ನಿಜವಾಗಿ ಅವರಿಗೆ ಈಗ ಆಗ್ಬೋದು, ಮೋದಿಯ ಮೀಟಿಂಗ್ ಎಲ್ಲ ಮುಗ್ದ ನಂತರ ಅವರಿಗೆ ಆಗ್ಬೋದು, ಅಣ್ಣೆಯರ ಮಾತಿಗೆ ನಾನು ಬೆಲೆ ಕೊಡಬೇಕಿತ್ತು ಅಂತ ಅಷ್ಟು ಕಷ್ಟಪಟ್ಟಿದ್ದಾರೆ ಅವರು. ನಮ್ಮ ಈ ಸಾರ್ವಜನಿಕ ಸಂಪರ್ಕಾಧಿಕಾರಿ ಆದ ನಂತರ ನಮಗೆ ಅದೆಷ್ಟು ಕೆಲವು ಕೆಲಸಗಳಲ್ಲಿ ತೊಡಗಿಸಿಕೊಂಡಿದ್ದಾರೆ, ಸಾರ್ವಜನಿಕರಿಗೆ ಉಪಯುಕ್ತವಾಗುವಂತಹ ರೀತಿಯಲ್ಲಿ. ಸೊ ಅವರನ್ನು ಕೂಡ, ಹಾಗೆ ನಮ್ಮ ರಾಮಚಂದ್ರ ಕಾಮತ್ರು, ಆಮೇಲೆ ನಮ್ಮ ದಿವಾಕರ್ ರಾವ್, ನಮ್ಮ ಸಂಘಬಿತ್ತಿಲು, ನನ್ನ ಕ್ಲಾಸ್ಮೇಟ್, ಇವರನ್ನು ಕೂಡ ನಾನು ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ, ನನ್ನ ಪರವಾಗಿ ಈ ಒಂದು ವೇದಿಕೆಗೆ ಆಹ್ವಾನಿಸ್ತಾ ಇದ್ದೇನೆ. ತುಂಬ ಸ್ವಾಗತವನ್ನು ಕೊಡ್ತಾ ಇದ್ದೇನೆ. ಹಾಗಲ್ಲ, ಶರೀರ ಜರ್ಜರಿ ಕೂತೆ ವ್ಯಾಧಿಗಸ್ತೆ ಕಳೆಯಬರೆ ಔಷಧಂ ಜಾಮೀಯ ತೋಯಂ ವೈದ್ಯೋ ನಾರಾಯಣ ಹರಿಹಿ. ಆದರೆ ಬಹುಶಃ ಆ ನಾರಾಯಣ ಅಥವಾ ನಮ್ಮ ದೇವ ಯಾರೇ ಇರಲಿ, ನಾವು ಎಲ್ಲರೂ ನಂಬುವಂಥ ಒಬ್ಬ ದೇವ, ಅವನಿಗೆ ನಮ್ಮ ಭವಸಾಗರವನ್ನು, ಆಕ್ಚುಲಿ ಹೇಳೋದು ಭವಸಾಗರದಿಂದ ದಾಟಿಸಬೇಕು ಅಂತ ಹೇಳಿ, ರೋಗದಿಂದ ದಾಟಿಸಬೇಕು ಅಂತಲ್ಲ. ಆದರೆ ಸ್ವಲ್ಪ ಮಟ್ಟಿಗೆ ನಾವು ವೈದ್ಯರಾದವರು ಬಹುಶಃ ಭವದಲ್ಲಿ ಬರುವಂಥ ರೋಗಗಳನ್ನು ಗುಣಪಡಿಸಲಿಕ್ಕೆ ಪ್ರಯತ್ನ ಮಾಡ್ತೇವೆ. ಆದ ಕಾರಣ ಬಹುಶಃ ನಮಗೆ ಜನ ನಮ್ಮನ್ನು ದೇವರು ಅಂತ ಹೇಳಿದರೆ ನಾವು ಬರುವಂತಹ ಒಂದು ಪರಿಶ್ರಮ ಅಥವಾ ನಮ್ಮ ಕಾರ್ಯತತ್ಪರತೆ, ಇದರಿಂದಾಗಿ ಅಥವಾ ನಾವು ತೋರಿಸುವಂಥ ಪ್ರೀತಿ ಕಾಳಜಿಯಿಂದಾಗಿ ಬಹುಶಃ ಜನ ಇಂದು ನಮ್ಮನ್ನು ದೇವರು ಅಂತ ಹೇಳಿ ಕಲಿದ್ರೆ ತಪ್ಪಾಗ್ಲಿಕ್ಕಿಲ್ಲ. ಹಾಗಾಗಿ ನಮ್ಮ ನಿಜವಾದ ಈ ಒಂದು ನಾವು ಏನು ಉದ್ಯೋಗ ಮಾಡ್ತೇವೆ ಅದು ನಿಜವಾಗಿ ಒಂದು ಉತ್ತಮವಾದ ಒಂದು ಉದ್ಯೋಗ. ಜನತಾ ಸೇವೆ ಮಾಡಲಿಕ್ಕೆ, ಜನತಾ ಸೇವೆ, ಜನಾರ್ದನ ಸೇವೆ, ಅದೊಂದು ರೀತಿಯಲ್ಲಿ ನಾವು ಮಾಡುವಂತಹ ದೇವರ ಸೇವೆ ಅಂತ ಹೇಳಿದ್ರೆ ತಪ್ಪಾಗಲಿಕ್ಕಿಲ್ಲ. ಆಮೇಲೆ ಸಭೆಯಲ್ಲಿ ಇರುವಂತಹ ಎಲ್ಲ ನಮ್ಮ ಹಿರಿಯ ಕಿರಿಯ ಭಾರತೀಯ ವೈದ್ಯಕೀಯ ಸಂಘದ ಸದಸ್ಯರುಗಳು ಇಂದು ನಮ್ಮಿಂದ ಪುರಸ್ಕಾರಗೊಳ್ಳಲಿಕ್ಕೆ ಬಂದಿದ್ದಾರೆ. ನಮ್ಮವರೇ ಆದಂತಹ ಕೆಲವು ವೈದ್ಯ ಮಿತ್ರರು, ಡಾಕ್ಟರ್ ಜೈನ್ ಭಟ್ ಇದ್ದಾರೆ, ಡಾಕ್ಟರ್ ಡೆನ್ಸಿಲ್ ಪಿಂಟೋ ಇದ್ದಾರೆ, ಆಮೇಲೆ ಡಾಕ್ಟರ್ MC ಸುವರ್ಣ ಕೂತ್ಕೊಂಡಿದ್ದಾರೆ. ಆಮೇಲೆ ಇವರು ವತ್ಸಲ ಕಾಮತ್ ಬರಬೇಕಿತ್ತು, ಆದರೆ ಗಳಿಗೆಯಲ್ಲಿ ಏನೋ ಒಂದು ಕಾರಣದಿಂದ, ಅನಿವಾರ್ಯ ಕಾರಣದಿಂದ ಅವರಿಗೆ ಬರಲಿಕ್ಕಾಗಲಿಲ್ಲ. ಸೊ ಅವರು ಕೂಡ ನಮ್ಮ ಕರೆಗೆ ಹೋಗ್ಕೊಂಡು ಬಂದಿದ್ದಾರೆ. ಅವರನ್ನು ಕೂಡ ನಾನು ನಿಮ್ಮೆಲ್ಲರ ಪರವಾಗಿ ಆದರದಿಂದ ಸ್ವಾಗತಿಸ್ತಾ ಇದ್ದೇನೆ. ಅಷ್ಟು ಮಾತ್ರ ಅಲ್ಲ, ನಮ್ಮ ಇಲ್ಲಿಯ ಸ್ವಯಂ ಸೇವಕರಿರ್ಬೋದು, ಸುಶಾಂತ್ ಇರ್ಬೋದು, MC ಮಾಡಿದಂತಹ ನಮ್ಮ ಜಗತ್ತನ್ನ, ಮತ್ತೆ ಸೌಮ್ಯ ಮೇಡಮ್, ಆಮೇಲೆ ನಮ್ಮೊಂದಿಗೆ ಇರುವಂತಹ ಇವರು ಎಲೆಕ್ಟ್ರಿಷಿಯನ್ಸ್, ಮತ್ತೆ ನಮ್ಮ ಸೌಂಡ್ ಸಿಸ್ಟಮ್ನವರು, ಮಾಧ್ಯಮ ವರ್ಗದವರು, ಪ್ರೆಸ್ ಮೀಡಿಯಾದವರು, ಇವರೆಲ್ಲರನ್ನೂ ಕೂಡ, ಮತ್ತೆ ಯಾರನ್ನು ಅದು ಬಿಟ್ಟೋಗಿದ್ರೆ ಕ್ಷಮಿಸಿ, ಎಲ್ಲರನ್ನೂ ಕೂಡ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ತುಂಬ ಹೃದಯದಿಂದ ಸ್ವಾಗತಿಸುತ್ತಿದ್ದೇನೆ. ಜೈ ಹಿಂದ್, ಜೈ ಕರ್ನಾಟಕ.
As you all know, Professor Dr. Shantaram Shetty doesn't require any introduction, and he doesn't like it also. Many a times in all our functions, he refuses any formal introduction. But it is customary, and as you are the role model for many of us, especially youngsters, we don't mind hearing about you umpteen number of times. Dr. Shantaram Shetty, the director of Tejaswini Hospital and SSIOT, and Pro-Chancellor of prestigious NITE deemed to be university. Sir has done his MBBS long back, 1965 from Mysore Medical College, and completed his MS from Maulana Azad Medical College, and has got many fellowships, including Fellow of American College of Surgeons, Fellow of Royal College of Surgeons, Fellow and member of International College of Surgeons, and of course, Fellow of Indian College of Surgeons. After his post-graduation, he started his career in Kasturba Medical College, Mangalore, and he served the institute as head of the department and director of postgraduate studies. He later moved to K.S. Hegde Medical Academy as the dean, continued there as the vice chancellor, and at present he is working as the pro-chancellor hospital administration for NITE deemed to be university. He has got many awards and honors to his credit. He has got the prestigious Kannada Rajyotsava Award, the Vandana Award from Rotary, and as he has served the prestigious Lions Club International as district governor long back with the Lion MJF Fellowship. He has got many awards in Lions from the Lions International President for his work, as well as work in specialty, as well as in social activities. Being a multifaceted personality, in addition to being a great surgeon, a great teacher, he is actively involved in social service and also in non-governmental organizations. He is involved in Red Cross Society, in Dakshina Kannada Handicapped Association since a long time, and he was instrumental in starting Lions Artificial Center, through which he has provided artificial limbs, I think nearly for a lakh of people. That is a great achievement for any socially involved person. In his specialty, the Association of Orthopedics, whatever that is possible, he has achieved. He was the president of State Association, he was the president of National Orthopedic Association, and he has risen up to international level. He has served as in different capacity in Association of Orthopedics International, including the chairman concerned with India. He is a great teacher, and he has given lectures in many CMEs. He has lot of publications, more than around 160 publications. He has published books. He has written chapters in many books. And during COVID time, definitely he was not at all lazy. He has utilized that opportunity to write books in English as well as Kannada, especially in yoga and other social concerns. I think that is a great contribution to the society. He was his contribution, especially to NITTE deemed to be university, is great. Because of him, NITTE deemed to be university presently has got A+ NAC accreditation. So, which definitely needs a great applause. He is getting awards. Now also he is getting awards. Recently he has received one of the prestigious award for charitable institutions. We got for Justice K. Segde Hospital, the best charitable hospital from in the state, and being the Pro-Chancellor of Hospital Affairs, his contribution is great. So, thus I am introducing Professor Shantaram Shetty, a great surgeon, teacher of teachers, and above all, a great human being. Thank you.
To introduce Dr. B. Gunnikrishnan, the Dean of KMC Mangalore, and my own Dean, who is a professor of community medicine also at Kasturba Medical College, Mangalore. He was a former head of the Department of Community Medicine and the Deputy Director of Student Affairs at Manipal Academy of Higher Education. His areas of interest is in evidence synthesis, health policy, and global health. He is a collaborator for the Global Burden of Disease at the University of Washington. He is in the advisory board of JIPMA Research Leadership Mentoring Program at Pondicherry. The governing board of Cochrane has admitted him to the membership of Cochrane Collaboration from 2018 to 2023. He has published more than 250 articles in peer-reviewed Scopus Index journals, including Lancet and Nature. He is presently serving as the Associate Editor for BMC Public Health Journal, Academic Editor for PLOS One, and Academic Editor for AIDS Research and Treatment, and the Editorial Board member of Indian Journal of Community Medicine. He is a member of the NAC peer team and NABH assessor. Presently, he is the principal investigator of the hospital-based cancer registry funded by ICMR, and co-principal investigator for 2 ICMR-funded research projects on childhood injuries, and co-principal investigator for 2 ICMR-funded systematic reviews. He has received the fellowship from Sparkman Center for Global Health, the University of Alabama at Birmingham School of Public Health, United States, and the Department for Interventional Development, DFID, UK, fellowship at South Asian Cochrane Centers, CMC, Vellore, India. He is presently the member of the Standing Expert Peer Committee for Public Health Research Initiative Research Grant under the Department of Science and Technology, Government of India, and Public Health Foundation of India, PHFI. He is an external expert for ICMR extramural research project in the field of health systems research, social and behavioral research, chronic disease, mental health, HIV and public health. Is also the expert for Science and Engineering Research Board, Government of India, in the domain of life sciences and subdomain of health sciences. He is our latest dean. He is taken over as the dean on the 1st of January 2022. I also congratulate him for KMC continuing to break up into the India Today Medical College ranking, and we have made up 2 places from the previous year. I welcome you, sir. I present Dr. Gunnikrishnan to the audience. Thank you.
I recognize the presence for their support.
Thank you, Dr. Prakash, for the introduction. Ladies and gentlemen, as you are all aware, National Doctors' Day commemorates the birth anniversary of Dr. B.C. Roy, a great stalwart who strode the diverse fields of medicine and politics.
Shantaram Shetty, sir, our Dean, Dr. Gunnikrishnan, sir, our IMA Trust President, Dr. Divakar Rao, and PRO, Dr. Kulal, and my friend and guide, Dr. G.K. Bhatt, the State PRO, and beloved Secretary, Dr. Sadanand Pujari, and respected members of the IMA. It's my proud privilege and honor to read about our today's day, that is we are commemorating the birth and also the death anniversary of Dr. Bidhan Chandra Roy. Born on July 1st, 1882, and same day, that is 1st July 1962, he left us. He was a bachelor and architect of West Bengal and was very popular next to Subhash Chandra Bose. He was a doctor, educationist and freedom fighter and chief minister of West Bengal. And he joined politics because of Mahatma Gandhi and also during the civil disobedience movement. His qualifications, he did MBBS, MD and both MRCP and FRCP in 2 years in London. He got this admission after a long fight. And in 1911, he joined Calcutta Medical College as a teacher. He treated his practice to serve humanity, not as a profession. He considered that I see God in patients. He treated his patients with love, compassion and charity, and patients treated him as God. He used to ride bicycle in small lanes of Calcutta, see patients. He dedicated his service to the public health and welfare. He built TB hospital and children's hospital in Calcutta in his own cost, and he urged the doctors' fraternity to have sympathy towards the patient. His positions in political career: in 1928 he was the AICC Executive Committee member, 32 to 33 Calcutta City Corporate Mayor, 41 to 44 he was the Vice Chancellor of Calcutta University, and 48 to 52, and after that till 62, till his sad demise, he was the Chief Minister of West Bengal. Medicine was his first love. He rose to the eminence of a physician. His proficiency in surgery was also known to many. Even the President Kennedy sought his treatment for a bone injury he sustained during the Second World War, which used to give him occasional pain in his back, which American orthopedicians could not cure. They called Roy and examined Kennedy and prescribed a course of medicines. Later he received and he sent a thanks letter to the Roy that there had been no recurrence of pain after his treatment. Dr. Bidhan Chandra Roy was a bachelor, and after a brief illness, he died on the date that he was born, that is on July 1st, 1962. ಇಂತಹ ಮಹಾನ್ ವ್ಯಕ್ತಿತ್ವ, ವೈದ್ಯ, ರಾಜಕಾರಣಿ, ಮಾನವೀಯತೆಯ ಸಾಕಾರ ಮೂರ್ತಿಯಾದ ಇವರ ಸಾಕಾರ ಮೂರ್ತಿಯ ಮಾರ್ಗದರ್ಶಕರು ಆಗಿದ್ದಂತಹ ಇವರನ್ನು ನಾವೆಲ್ಲರೂ ನೆನೆಸೋಣ ಮತ್ತು ಅನುಕರಿಸೋಣ. Thank you very much.
The felicitation of doctors. We have 4 eminent personalities for whom IMA Mangalore branch has been selected for felicitation. Each of them have rendered a lifetime of dedicated exemplary service to society and thereby gained respect and admiration in their respective fields. They are Dr. MC Suvarna, consultant urologist, Dr. Denzil Pinto, consultant psychiatrist, Dr. J.N. Bhatt, family physician, and Dr. Vatsala Kamath, consultant gynecologist. To begin with, I call upon Dr. MC Suvarna sir to kindly take his place on the ceremonial chair.
Schoolmate, he was 3 years senior to me in school, and now of course my teacher later on, my teacher when I was doing my MS in Manipal, and now a good friend of mine, Dr. Mohan Chandra Suvarna. He is a consultant urologist practicing in Sanjeevani Clinic in Fadneer. He is professor of urology and head of urology, DNB coordinator, Mangalore Hospital, Mangalore. He is ex-head of urology in KMC, Mangalore. He was ex-head of urology and director of MCH. Urology started in, he was the third candidate who completed his MCH from urology, MCH urology in Manipal in the year, I think, 1988. 83. He was doing his MCH when I was doing my MS in Manipal in those days. He has been an examiner for MCH Urology from Mangalore University, Trivandrum Medical College, Calicut Medical College, KMC Manipal, and Father Muller's Medical College. He has presented many scientific papers at conferences and has had many publications and has chaired many scientific sessions at All India conferences. He has delivered the oration at the Association of Surgeons of Karnataka conference at Mysore, and also the oration at the ASI conference at Mangalore chapter. And member of the Association of Surgeons of India, member of the Urological Society of India and various zonal chapters. His MBBS MS was from KMC Mangalore and MCH Urology from KMC Manipal. He is married to Mrs. Sujata and has 2 children, Swarup Rani and Siddharth. Ladies and gentlemen, I have great pleasure in introducing my good friend, Dr. Mohan Chandra Suvarna.
Once again recognize on behalf of IIM Mangalore, they thank them for their support.
So it is a proud privilege to introduce another psychiatrist. I was also a psychiatrist. Dr. Denzel Pinto completed his primary and secondary education in Mangalore and then joined prestigious St. John's Medical College and completed MBBS in 1972. Then he went to work in Ireland and Nigeria and came back to India and did his diploma in hospital administration from CMC Vellore. And then he did his MD psychiatry from Father Muller Medical College. And then he worked as a psychiatrist from 1992 to 2018 and he retired as professor of psychiatry in 2018. And he also served as a deputy medical superintendent of Father Muller Medical College Hospital until 2018. And he also served as A-class trustee of AA, that is Alcohol Anonymous, in India. And he has been recipient of several awards, including Senior Psychiatrist Award by Karnataka branch of Indian Psychiatry Society in 2008. And his areas of special interest include de-addiction and geriatric psychiatry. And he has been resource person and given many talks in subject in Mangalore and Udupi.
Thank you, Dr. Ulas Sherry, for the introduction. I request.
Of the print and digital media on behalf of IIM Mangalore.
ಕೋಟೆಗಾರನವರು ಜೆ ಅಂದರೆ ಜನ್ಕಲ್, ಎನ್ ಅಂದರೆ ನಾರಾಯಣ ಭಟ್, ಜನ್ಕಲ್ ನಾರಾಯಣ ಭಟ್, ಬಾಳ ಹಸನ್ಮುಖ್. 30/11/1948 ಜನಿಸಿದ ಡಾಕ್ಟರ್ ಭಟ್ ಇವರು ಅವರ ಪ್ರಾಥಮಿಕ ಶಿಕ್ಷಣಗಳನ್ನು ಮಂಗಳೂರಿನ ಸರಹದ್ದಿನಲ್ಲಿ ಮುಗಿಸಿ ತದನಂತರ ಹೈಸ್ಕೂಲು ಹಾಗೂ PUC ವಿದ್ಯಾಭ್ಯಾಸಗಳನ್ನು ಇಲ್ಲೇ ಮಾಡಿ ನಂತರ ಮೈಸೂರು ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನಲ್ಲಿ ಉತ್ತಮ ಅಂಕಗಳನ್ನು ಪಡೆದುಕೊಂಡ ಮೂಲಕವಾಗಿ ಸರ್ಕಾರಿ ಕಾಲೇಜಿನಲ್ಲಿ MBBS ವ್ಯಾಸಂಗಕ್ಕೆ ಸೇರಿದರು. 1974ರಲ್ಲಿ MBBS ಅಲ್ಲಿ ಉತ್ತಮ ಅಂಕಗಳೊಂದಿಗೆ ತೇರ್ಗಡೆಯಾದ ಇವರು ನಂತರ 1975ರಿಂದ ಹೌಸ್ ಸರ್ಜನ್ಸಿಯನ್ನು ಮುಗಿಸಿ ಪ್ರಾಕ್ಟೀಸ್ ಮಾಡಲಿಕ್ಕೆ ತೊಡಗಿದರು. ನಂತರ ಅವರು ಹೆಚ್ಚಿನ ವ್ಯಾಸಂಗಕ್ಕೆ ಬೇಕಾಗಿ ಲಂಡನ್ ಹಾಗೂ ಅಮೇರಿಕಾಗಳಿಗೂ ಹೋದರು. ಅಲ್ಲಿಯೂ ಫೆಲೋಶಿಪ್ಗಳಿಗೆ ಬೇಕಾಗಿ ಮಾಡಿ FRSH ಅನ್ನು ಲಂಡನ್ನಲ್ಲಿಯೂ FA
ಇಲ್ಲಿ ಅಮೇರಿಕದಲ್ಲಿಯೂ ಅವರು ಉತ್ತಮ ಅಂಕಗಳೊಂದಿಗೆ ಫೆಲೋಶಿಪ್ಪಿನ ಕೆಲಸಗಳನ್ನು ಪೂರೈಸಿ ಪುನಃ ಇಂಡಿಯಾಕ್ಕೆ ಹಿಂತಿರುಗಿದರು. ಇಂಡಿಯಾಕ್ಕೆ ಇಲ್ಲಿ ಹಿಂತಿರುಗಿದ ನಂತರ ಹಲವು ಸಂಸ್ಥೆಗಳಲ್ಲಿ ಚೀಫ್ ಮೆಡಿಕಲ್ ಆಫೀಸರ್ ಆಗಿ ಸೇವೆ ಮಾಡಿದರು. ಇದರ ಮೊದಲು ಅವರು ಮಸ್ಕತ್ತಿಗೆ ಹೋಗಿ ಅಲ್ಲಿ ಹೆಲ್ತ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ನಲ್ಲಿ ಅಲ್ಲಿ ಕೂಡ ಮಿನಿಸ್ಟ್ರಿ ಆಫ್ ಹೆಲ್ತ್ ಡಿಪಾರ್ಟ್ಮೆಂಟ್ನಲ್ಲಿ ಸುಮಾರು ವರ್ಷಗಳು ಅಲ್ಲಿ ದುಡಿದು ಬೇಕಾದಷ್ಟು ಹಣವನ್ನು ಮಾಡಿದರು. ಮತ್ತು ಸಂತೋಷ ಪರದೇಶಗಳಲ್ಲಿ ಇಲ್ಲ, ಅದು ಪರದೇಶಿಗಳಿಗೆ ಆಗಬಹುದು ಅಂತ ಹೇಳುವಂಥ ಅಭಿಪ್ರಾಯದಲ್ಲಿ ಇಲ್ಲಿ ಹಲವು ಆಸ್ಪತ್ರೆಗಳಲ್ಲಿ ಚೀಫ್ ಮೆಡಿಕಲ್ ಆಫೀಸರ್ ಆದರು. ಯಾವುದು ಅದರಿಂದ ಮೊದಲು ಮೈಸೂರು ಮೆಡಿಕಲ್ ಕಾಲೇಜಿನಲ್ಲಿ ಅವರು ಒಂದು ಮಿಷನ್ ಆಸ್ಪತ್ರೆಯಲ್ಲಿ ಚೀಫ್ ಮೆಡಿಕಲ್ ಆಫೀಸರ್ ಆಗಿ ಇದು ಮಾಡಿದರು. ಇದರಿಂದ ಮೊದಲನೇ ಸಂಗತಿ ನನಗೆ ಹೇಳಲಿಕ್ಕೆ ಬಿಟ್ಟೋಯಿತು. 1982ನೇ ಇಸವಿಯಲ್ಲಿ ನಂತರ ಇಬ್ಬರು ಹೆಣ್ಣು ಮಕ್ಕಳು, ಮಮತಾ ಭಟ್ ಮತ್ತು ಮೀರಾ ಭಟ್, ಹಾಗೆ ಅವರು ಕೂಡ ಉದ್ಯೋಗದಲ್ಲಿ ಇದ್ದಾರೆ. ಹಾಗಾಗಿ ಈಗ ಡಾಕ್ಟರ್ JN ಭಟ್ ಅವರು ವೆಲ್ ಸೆಟಲ್ಡ್. ಈಗ ಅವರು ಬ್ಲಡ್ ಬ್ಯಾಂಕ್ ಮೆಡಿಕಲ್ ಆಫೀಸರ್ ಆಗಿದ್ದಾರೆ. ಇದರಿಂದ ಮೊದಲು ಹಲವು ಆಸ್ಪತ್ರೆಗಳಲ್ಲಿ ಒಮೆಗಾ ಹಾಸ್ಪಿಟಲ್ನಲ್ಲಿ ಸೂಪರಿಂಟೆಂಡೆಂಟ್ ಆಗಿದ್ದರು, SS ಹಾಸ್ಪಿಟಲ್ನಲ್ಲಿದ್ದರು, ಮತ್ತೆ ಯಾವುದು ಮ್ಯಾಂಗ್ಳೂರ್ ನರ್ಸಿಂಗ್ ಹೋಮ್ನಲ್ಲಿ ಇದ್ದರು. ಎಲ್ಲ ಕಡೆಯ ಎಲ್ಲ ಆಸ್ಪತ್ರೆಗಳ ಕಥೆಯೂ ಅವರಿಗೆ ಗೊತ್ತುಂಟು ಸರಿಯಾಗಿ. ಹೀಗೆ ಇಂಡಸ್ಟ್ರಿಯಲ್ MRP ಅಲ್ಲಿ ಕೆಲಸ ಮಾಡಿದವರು. ಅವರು ಹೋಗದ ಪ್ಲೇಸ್ ಇಲ್ಲ ಬಹುಶಃ ನನಗೆ. ಈಗ ಯಾವ್ದಾದ್ರು ಬಿಟ್ಟರೆ ನೀವು ಈಗ ವಾಪಸ್ ಹೇಳ್ಬೋದು JN ಭಟ್ರೆ. ಹಾಗೆ ಇನ್ನು ಅವರ ಒಂದು ಆಕ್ಟಿವಿಟೀಸ್ಗಳನ್ನು ನೋಡಿದರೆ ನನಗೆ ಅದನ್ನು ಹೇಳಲೇಬೇಕು. ಅವರೊಂದು ಯಕ್ಷಗಾನ ಪ್ರಿಯರು. ಸತ್ಯಮೂರ್ತಿ ಅಂತ ಅವರು ಹಿಂದೆ ಇದ್ದಾರೆ, ಅವರೊಟ್ಟಿಗೆ ಹಲವು ಇದರಲ್ಲಿ ಕಾರ್ಯಕ್ರಮಗಳಲ್ಲಿ ಅವರು ತೊಡಗಿಸಿಕೊಂಡವರು. ಅದರಲ್ಲಿಯೂ ನನಗೆ ನೆನಪು ಬರೋದು, ನನ್ನ ಒಂದು ನೇತೃತ್ವದಲ್ಲಿ ಆದಂತಹ ಒಂದು ಕೃಷ್ಣನಿಗೆ ಕಂಸವದೆ, ಭಸ್ಮಾಸುರ ಮೋಹಿನಿ, ಇದರಲ್ಲೆಲ್ಲ ಭಸ್ಮಾಸುರ ಮೋಹಿನಿಯಲ್ಲಿ ಅವರು ಮೋಹಿನಿಯಾಗಿ ಇದ್ದರೂ ಮೋಹಿನಿಯ ಪಾತ್ರ ಮಾಡಲಿಕ್ಕೆ ಹೋಗಲಿಲ್ಲ. ಅವರು ವಿಷ್ಣುವಾಗಿ ಬಹಳ ಒಂದು ಅತ್ಯುತ್ತಮವಾದ ನಟನೆಯೊಂದಿಗೆ ಮಾತುಗಾರಿಕೆಯೊಂದಿಗೆ ಎಲ್ಲರನ್ನು ಆಕರ್ಷಿಸಿದ್ದಾರೆ. ಇನ್ನು ಕೃಷ್ಣಲೀಲೆ ಕಂಸವದೆ ಇದರಲ್ಲಿ ಅಗಸನ ಪಾತ್ರ, ಅವರಿಗೊಂದು ಹಾಸ್ಯಗಾರನ ಉದ್ಯೋಗ ಹೇಗೆ ಮಾಡಬಹುದು ಅಂತ ಹೇಳುವುದನ್ನು ಒಂದು ಸಮರ್ಥವಾಗಿ ಇಲ್ಲಿ ತೋರಿಸಿ ಹೆಚ್ಚು ಕಡಿಮೆ ಆವಾಗ ಒಂದು 300 ಜನ ಇಲ್ಲಿ ಸೇರಿದ್ರು. ಅಂಥವರ ಸಮಕ್ಷಮದಲ್ಲಿ ನಿಜವಾದ ಒಂದು ಅಗಸನೆ. ಇವನಿಗೊಂದು 1,000 ರೂಪಾಯಿ ದಿವಸಕ್ಕೆ ಆಟಕ್ಕೆ ಹೋದ್ರು ಅವರಿಗೆ ಸಂಬಳ ಕೊಡ್ಬೋದು. ಯಕ್ಷಗಾನಕ್ಕೆ ಎಲ್ಲಾರು ಮೇಳದಲ್ಲಿ ಹೋದ್ರೆ 1,000 ರೂಪಾಯಿ ಸಂಬಳಕ್ಕೆ ತೊಂದರೆ ಇಲ್ಲ. ಡಾಕ್ಟರ್ ಉದ್ಯೋಗ ಬಿಟ್ಟರು ಅಲ್ಲಿ 1,000 ರೂಪಾಯಿ ಸಿಗ್ತದೆ ಅಂತ ಹೇಳುವಷ್ಟು ಒಂದು ಪ್ರಾವೀಣ್ಯತೆಯನ್ನ ತೋರಿಸಿದಂತ ಡಾಕ್ಟರ್ JN ಭಟ್ರು. ಇನ್ನು ಅದ್ಭುತಾಸುರ ಕಾಳಗ ಡಾಕ್ಟರ್ ಸತ್ಯಮೂರ್ತಿಯವರ ನೇತೃತ್ವದಲ್ಲಿ ಆದದ್ದು. ಅದರಲ್ಲಿ ಕುಡಿಯದಂತ ಡಾಕ್ಟರ್ JN ಭಟ್ರು ಕುಡಿದ್ರೆ ಏನಾಗ್ತದೆ ಹೇಗೆ ಅಂತ ಹೇಳುವುದನ್ನ ಹುಡುಗರಿಂದ ಹೆಚ್ಚು ಚಂದವಾಗಿ ಎಲ್ಲರಿಗೂ ತೋರಿಸಿಕೊಟ್ಟಿದ್ದಾರೆ. ಅವರು ಮಾಡಿ ತೋರಿಸಿದವರು ಡಾಕ್ಟರ್ JN ಭಟ್ರವರು. ಇನ್ನೊಂದು ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಅವರು ಭಾಗಿಯಾಗಿದ್ದು ಯಕ್ಷಗಾನ ಎಲ್ಲಿ ಸಿಕ್ಕಿದ್ರು ಕಡೆಗೆ ಇತ್ತೀಚೆಗೆ ಅವರ ಪ್ರಾಯಕ್ಕೆ ಸರಿಯಾಗಿ ಒಂದು ವೇಷ ಅವರಿಗೆ ಸತ್ಯಮೂರ್ತಿ ಅವರು ಕೊಟ್ಟರು. ಕನ್ನಡದಲ್ಲಿ ಸಾಕುಮಾರ ಎಲ್ಲ ಮಾಡಿದ್ದು. ಇನ್ನೊಂದು ಇಂಗ್ಲಿಷಿನಲ್ಲಿ ನಾವು ಒಂದು ಆಕ್ಟ್ ಮಾಡುವ ಅಂತ ಏಳಿಗೆ ಕೊಡದ ಸತ್ಯಮೂರ್ತಿಯವರ ಹನುಮಂತ ಹಾಗೂ ಇವರ ಒಂದು ಜಾಂಬವಂತ. ಅದೊಂದು ಇಂದ್ರಜಿತ್ತು ಕಾಳಗದಲ್ಲಿ ಇವರ ಇಬ್ಬರ ಪಾತ್ರವನ್ನು ನಾನು ಟೌನ್ ಹಾಲ್ನಲ್ಲಿ ನೋಡಿದ್ದೇನೆ, ಪುರಭವನದಲ್ಲಿ ಇತ್ತೀಚೆಗೆ. ಬಹಳ ಚೆನ್ನಾಗಿ ಮಾತಾಡಿದ್ದಾರೆ. ಅವರೊಂದು ಹನುಮಂತನನ್ನು ಒಂದು ನೋಡುವಂತಹ ಒಂದು ವೈಖರಿ ಬಂದು ಮಾತಾಡಿಸುವುದು, ಆಮೇಲೆ ಹನುಮಂತ ಒಂದು ನಡೀಲಿಕ್ಕೆ ಕೂಡಲವ ಎಷ್ಟು ಕಷ್ಟದಲ್ಲಿ ಆದರೂ ಆಚೆ ಈಚೆ ನಿಲ್ಲುವಾಗ ನಿಜವಾದ ಹನುಮಂತನಿಗೆ ನಮ್ಮ ಸತ್ಯಮೂರ್ತಿ ನಟನೆಗಳನ್ನು ಮಾಡಿದ್ದಾರೆ. ಯಕ್ಷಗಾನದಲ್ಲಿ ಬಡಗುತಿಟ್ಟಿನವರಿಂದ ತೆಂಗುತಿಟ್ಟಿನವರಿಂದ ಎಲ್ಲರಿಂದಲೂ ಒಂದು ಪ್ರೋತ್ಸಾಹ ಹಾಗೂ ಒಂದು ಮೆಚ್ಚುಗೆಯ ಮಾತುಗಳನ್ನ ಕೇಳಿದವರು ಯಶಸ್ವಿಯಾಗಿದ್ದಾರೆ. 74 ವರ್ಷ ಚಿರ ಯುವಕ. ಈಗ ನೋಡಿದ್ರು ನಗಾಡ್ತಾರೆ. ನಗಾಡೋದೊಂದು ಅವರ ಸೊತ್ತು, ಅದೇ ಒಂದು ಅಟ್ರಾಕ್ಷನ್. ಡಾಕ್ಟರ್ ಶಾಂತಾರಾಮ್ ಶೆಟ್ಟಿ ಅವರು ಯಾವ ತರ ನಗುಮುಖದಿಂದ ಎಲ್ಲರನ್ನು ಆಕರ್ಷಿಸ್ತಾರ, ಅದೇ ತರ ನಮ್ಮ ಒಂದು ಜನರಲ್ ಪ್ರಾಕ್ಟೀಷನರ್ ಪೈಕಿ ಅಥವಾ ಇದರಲ್ಲಿ ಅವರು ಡಾಕ್ಟರ್ ಜೆ.ಎನ್. ಭಟ್ರವರು ಒಂದು ಬರೆಯಲ್ಲಿ ನಗೆಯಲ್ಲಿ ಅವರು ಆಕರ್ಷಿಸ್ತಾರೆ. ಅವರು IMA ಲೈಫ್ ಅವರು ಮೊದಲಿಂದಲೂ ಕೂಡ ನಮ್ಮ ಫ್ಯಾಮಿಲಿ ಡಾಕ್ಟರ್ ಅಸೋಸಿಯೇಷನ್ನ ಒಂದು ಆಕರ್ಷಣೀಯ ವ್ಯಕ್ತಿ. ಪ್ರೇಯರ್ಗೆ ಯಾರು ಇಲ್ಲದಿದ್ದರೆ ಡಾಕ್ಟರ್ ಜೆ.ಎನ್. ಭಟ್ರು ಅಷ್ಟು ಚಂದವಾಗಿ ಪ್ರೇಯರ್ ಅನ್ನು ಹೇಳಿ ಅದರಲ್ಲಿರುವಂತಹ ವಿಷಯಗಳನ್ನ ಎಕ್ಸ್ಪ್ಲೈನ್ ಮಾಡೋದು. ಅವರು ಹೇಳುವ ಪ್ರೇಯರ್ ಯಾರಿಗೂ ಅರ್ಥ ಆಗುವಂಥದ್ದಲ್ಲ. ಒಂದು ಡಾಕ್ಟರ್ ಜೆ.ಎನ್. ಭಟ್ರನ್ನ ಇವತ್ತು ನಮ್ಮ ವೈದ್ಯರ ದಿನಾಚರಣೆಯಂದು ಅಲ್ಲದಿದ್ದರೂ 3ನೇ ತಾರೀಕಾದರೂ ಕೂಡ ವೈದ್ಯರ ದಿನಾಚರಣೆ ಜುಲೈ ತಿಂಗಳಲ್ಲಿ ಇಡೀ ಹಾಗೆ ನಾವು ಕನ್ಸಿಡರ್ ಮಾಡಿದ್ವಿ. ಯಾಕೆಂತ ಹೇಳಿದರೆ ಅದು ಕೆಲವರಿಗೆ ಕೆಲವು ದಿವಸ ಮಾತ್ರ ಅನಾನುಕೂಲವಾಗಿ ಬರ್ತದೆ. ಅದಕ್ಕೆ ಬೇಕಾಗಿ ನಾವು ಇವತ್ತು ಇಟ್ಟುಕೊಂಡದ್ದು. ಇವತ್ತು ನಿಮ್ಮನ್ನ ನಾವು ಸನ್ಮಾನಿಸ್ತಿರುವುದು ಡಾಕ್ಟರ್ ಜೆ.ಎನ್. ಭಟ್ರನ್ನ ನಿಮಗೆಲ್ಲ ಪರಿಚಯಿಸ್ತಾ ಇವತ್ತಿನ ಒಂದು ವೈದ್ಯಕೀಯ ಪ್ರಶಸ್ತಿಯನ್ನು ನೀಡುವಂತಹ ಸಂದರ್ಭ ನನಗೆ ಒಂದು ಪರಿಚಯಿಸಲಿಕ್ಕೆ ಅವರನ್ನೊಂದು ಸದವಕಾಶ ಸಿಕ್ಕಿದಲ್ಲ ಅಂತ ಹೇಳಿ ಹೇಳುತ್ತಾ ಅವರ ಮುಂದಿನ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ನಾವು ತೊಡಗೋಣ. ಜೈ ಹಿಂದ್.
Recognize the presence and support of the print and digital media on behalf of
ಸರ್ ಸ್ವಲ್ಪ ಹಾಂ ಇಲ್ಲಿ ಎದುರು
all the questions correctly. So he wins the prize for the quiz of the May issue. And the next issue of Medical will contain a quiz by Dr. Sadashiv Patnaik himself. So I request Dr. Sadashiv Patnaik to come on stage and accept this prize from Dr. Shantaram Shetty.
Congratulations, Dr. Patnaik, for that wonderful achievement.
Shantaram Shetty sir is picking up the female doctor, female lucky doctor.
And the lucky doctor is Dr. Soumya.
ಇಲ್ಲಿ ನೋಡಿ ಇಲ್ಲಿ ಇಲ್ಲಿ
Dr. U. Kumaraswamy.
The award of felicitation from IMA Mangalore, which is chosen me for the services I rendered. I don't know whether I deserve it or not. I should thank the IMA for giving this opportunity. The IMA, when I joined long time back in Mangalore, in a small number, and it was to be in some hotels. They used to conduct meetings. Now, thanks to the government and the senior members of the IMA and other doctors who joined together and put a beautiful auditorium here, I should thank all of them. I can't recollect all of them, but mainly Dr. Diwakar Rao's father and Dr. Shantaram Shetty and others, Habib Rahman, all those things, people were there who did a yeoman service and felicitated, got this IMA hall. Everything is going on smoothly in IMA, but my only concern is some of the things which I say the medico-legal aspects regarding our doctors and also atrocities created by the public against the doctors, and also litigations among ourselves. This thing has to be sorted out. I once again thank you, all of you, for giving this opportunity. Thank you very much.
Dr. Sadananda Pujari, Dr. K.R. Kamath, and all the office bearers of IMA for conferring upon me this honor today. It was in 1972 that I first attended as a young doctor the IMA meeting at Motimar. It was very stimulating. Since then, I am immensely benefited from all the talks, CMEs and programs that have been conducted by the IMA. Long live IMA, and thank you one and all.
Coming back to this, I'm happy you have selected me for this. ನಾವೆಲ್ಲ ಸಣ್ಣವರಿರುವಾಗ ಬಹುಮಾನ ಅಂತ ಸಿಗ್ತಿತ್ತು. ಸಣ್ಣ ಪುಟ್ಟ ವಿಷಯಗಳಿಗೆ ಬಹುಮಾನ. ಈ ದೊಡ್ಡದಾಗಿ 74 ಹತ್ರ ಆದಾಗೆ ಕೂದಲಿಂದ ಬಿಳಿ ಆದಾಗೆ ಸಣ್ಣ ಮಾನ ಅಂತ. ಹಾಗಾಗಿ ಈ ಪ್ರಶಸ್ತಿ ಇಂಥ ಸಮಾರಂಭಗಳನ್ನು ನಾವು ಸಾಕಷ್ಟು ನೋಡಿದ್ರಿಂದ ಆಯ್ಕೆಗೆ ನಾನು ಸಂತೋಷ ಪಡ್ತೇನೆ. ಎಷ್ಟು ಅರ್ಹನಾಗಿದ್ದೇನೋ ಗೊತ್ತಿಲ್ಲ, ಯಾಕಂದರೆ ಅದನ್ನು ಮೀರಿ ನಿಂತವರು ನಮ್ಮ ಎದುರಲ್ಲಿದ್ದಾರೆ, ಅಕ್ಕಪಕ್ಕದಲ್ಲಿದ್ದಾರೆ. ಬದುಕಿನಲ್ಲಿ ನಾವು ಡಾಕ್ಟರ್ಸ್ ಡೋಂಟ್ ರಿಟೈರ್ ಎಟ್ ಆಲ್. ದಟ್ಸ್ ಒನ್ ಥಿಂಗ್ ಆಲ್ ವಿ ನೋ ಇಟ್. So we all practice like lawyers. So every day we keep learning, and even today learn how not to talk long. But with all these things, as a doctor, I have learned quite a bit from Dr. Shantaram Chetty when I used to assist him in OT in Mangalore. I always felt it's a fitting name for him. And as I learned, as I grew for the past couple of decades, I started feeling there is a Sanskrit sloka where Satyamurti Ital said, Vaidyo Narayano Harihi. Next was good. But there is also the other side of it. Vaidyo Narayano Harihi Yama Harati Pranan Vaidya Dhananicha. So, all the doctors may not actually take a lot of money, hana, besides prana. But as doctors, my second thought is, Paropakaraya Phalanti Vrikshaha Paropakaraya Vahanti Natyaha Paropakaraya Duhanti Gavaha Paropakaram Idam Shariram. The trees will yield fruits not for themselves. The cow also gives milk, a little of it gives to the calf, much of it for the society and others. Even the rivers, though added by the tributaries, they irrigate the neighboring lands. So as human beings, as good doctors, we should be more and more available to others so that we will be more useful to others in the society. Particularly after joining the Red Cross, wherever I ran to blood camps, I always felt, because of my heart surgery, which was 55 years ago, 18 units of blood, those days, that's a heart-lung machine, different room, not like the present days. 18 units of blood has saved me. I have given 36 times, I have reached 74 now. I always tell people, if you are breathing in, breathing out also is a part of respiration. If you only breathe in and income, and you can't breathe out, ಪುನರ್ಜನ್ಮದಲ್ಲಿ ನಂಬಿಕೆ ಇರುವವರಿಗೆ ಅವರು ಉಬ್ಬಸದ ಆಸ್ಮಾ ಪೇಷಂಟ್ಸ್ ಆಗ್ತಾರೆ. Whether you believe it in Punarjanma or not, but I have gone through the life experience of near-death experience 3-4 times with my all experiences of near-death life, intensive care unit, viral myocarditis, and yoga and pranayama sustained me to be standing in front of you erect. I'm glad God has given me the opportunity. Probably some of my talks might be a little spicy for you, because science leads you to the experiments and you prove it, but spirituality leads you to the experience and you don't have to prove it. It's an inner growth. So beyond the inner net, beyond the internet, when you start connecting yourself to the inner net, you start feeling you have to face the devil of Maya delusion. And also follow the Master, who is a divine guide, your conscience in you, and fight till the end, finish the game. If you felt I was a little mirchi masala, I apologize for that. But at the same time, salt has no expiry. It's an age-long preservative. So salt, with a pinch of salt, you can take it. Thanks for being with me. Thank you.
There were a lot of speakers, ministers are there, MLAs are there. I thought I might skip or I will be sitting in one corner. I never thought that I will be getting this much award. Thank you, IMA man. Respected dignitaries on and off the dais, ladies and gentlemen, a hearty namaskara to each one of you present in this gathering. Let me first thank the IMA Mangalore for giving me this opportunity and also for felicitation. At the outset, we all must pay tribute and recognize our healthcare professionals for their untiring effort for the community to overcome the medical emergencies and pandemic situation. No one can forget their contribution during the COVID-19 pandemic, and they are still fighting the same. I will not say the guest of honor today, I will say the chief guest of today's function, Dr. M. Shantaram Shetty sir, an eminent orthopedician, already described as teacher of teachers, Director Tejaswini Hospital and Pro-Chancellor NITE, deemed to be university. Dr. Satyamurthy Aital P, President, first time I am meeting sir. I have heard a lot about him because we are planning to organize a national conference. Then people told me we have to invite the group, Aital group, for Yakshagana, that to in English. First time I am meeting you sir. Dr. Sadananda Pujari, I don't know what magic I did when he came to my chamber, that I don't know. This is my usual way of functioning. Okay, whatever you want to say, you entered inside, you requested, I just said okay. And that made me to get this felicitation. Thank you very much. Really, I appreciate it. Dr. G.K. Bhatt, I have known sir because her son was my student. Dr. K.R. Kamath, Dr. Diwakar Rao sir, our own Ananya Kulal, and I congratulate Mohan sir, Dr. M.C. Suvarna, Dr. Densil Pinto, Dr. J.N. Bhatt and Dr. Vatsala Kamath in absentia for their yeoman service to the society and being felicitated by IMA Mangalore branch. The theme for this year's National Doctors' Day, we have already forgotten this. I think when I was young also, we never used to go to a specialist or a super specialist. Always there was a doctor named as a family doctor or a family physician. That was our first contact. And most of the ailments were treated by that person. There was no need to go for a hospital, family physician. Aptly this year's theme for the National Doctors' Day is Family Doctors on the Front Line. The theme highlights the contribution of doctors for their service and dedication towards humanity. In many incidents, I think Mohan sir stated that, where doctors have never given up despite being attacked by patients and their relatives, continued their medical service for general population. No one can forget their contribution and tireless effort. In this regard, I would like to quote Seneca. Quote, "People pay the doctor for his trouble. For his kindness, they still remain in his debt." Unquote. This was told by Seneca, the famous philosopher. The pandemic COVID-19 has taught us many lessons. It has greatly disrupted the normal life, using health, economy, everything, but it has given us an opportunity to look at things differently and be self-dependent in future to tackle such challenges. Before COVID-19, we were exporting most of the healthcare product that we could have produced in India, but now we also are producing most of the items. Whether it is, you say it is a ventilator, whether it was a mask. I remember the first day when the COVID came, the mask and everything was so expensive. Now you get mask, homemade mask. It has taught us many things. Vaccine. We are the world's largest pharmacy. I am telling you, vaccine, 2 of the vaccines are not developed, one though not developed, but manufactured by Serum Institute, and Covaxin developed and manufactured in our country. We are not dependent on importing these items from abroad, paving the way towards our Modi ji's Atmanirbhar Bharat in health and other sectors. Many new innovations have helped ease the healthcare delivery, largely the digitalization and telehealth services. There is no need for always to go to hospital. A lot of things can be solved by digitalization, telehealth services, and even students for there. We have found that in the last 2 years, 2.5 years, there is no need for students to come to the college. We can take many of the things in online mode. Okay, and ultimately what will happen? The digitalization of the country has improved. The bandwidth everywhere, village also has internet connectivity. It's because of COVID. I once again thank the IMA Mangalore branch for giving me this opportunity. Thank you very much.
Dr. Sadanand and his wife, she was Soumya. She has done a great job as an MC, and the person who is in the forefront in all our IMA activities. I was sitting at home and watching what was going on at 4:30 and 5 o'clock and 5:30 and 6 o'clock in the IMA hall, and that is how Dr. Annaya Kulal acts. And our guest of honor, the Dean of KMC, who has to his credit more than 150 publications, and he has shown what a community medicine person can do in our field of research, Dr. Unni Krishnan, and the head of the Department of Orthopedics, who is celebrating 50 years of our post-graduation in KMC, Dr. Khyar, and a very senior neurosurgeon of our country, and who was in KMC. Then I met him in Trivandrum when he was doing his post-graduation, and it is great that he came back to Mangalore and practiced neurosurgery with great attributes. Dr. Divakar. G.K. Bhatt, who is always so whimsical, and he took us to different aspects of while introducing our guests. And the three main stalwarts who have been felicitated today. Dr. Mohan Chandra Suvarna. Dr. Mohan Chandra Suvarna was a byword in urology. He comes from a family of doctors. His father, I know, as a child, I used to see his board in Kulshekar, Dr. Umanath Suvarna, and he was one of the busiest general practitioners those days. And he is one of the lead urologists, and he has operated on me also. And thank you, Mom. And the dermatologists, psychiatrists of fame. Psychiatrists of fame, Dr. Denzel Pinto, and somebody mentioned, who introduced him said, Ulas, in his own whimsical way, he said he left off psychiatry and joined forensic medicine. But today I tell you, you missed something very great, because when I was a student, it was true that a famous American writer, he was a doctor. He said there are three types of doctors. One are called physicians, who do everything, but they do nothing. With all respects to our great Dr. Chakrapan. And the second are so-called surgeons, who know nothing, but they do everything. And the third are people called psychiatrists, who know nothing and do nothing. But today, it has turned 180%. My best student, who was my student's daughter, who got a gold medal in our medical college, who got the 300th rank in NEET, which was a record for our college, joined NIMANS in psychiatry department. So that is the turnabout which has taken place in psychiatry, and psychiatry is the subject which is going to rule our specialty. And Dr. Jayan, you are great. I know you as an youngster, and you have a multifaceted personality. And I should really give credit to Dr. Jain. He can speak on any subject. He can speak on medicine. He can speak on surgery. He can speak on any subject you give him. And I should really congratulate Dr. Satyamurthy and his whole team for selecting these great people for felicitation, because they really deserve this great felicitation. And we are not just felicitating 3 individuals, but we are felicitating the vibrancy of medical practice in Dakshina Kannada in particular. We are always proud in Dakshina Kannada for the medical fraternity. When I was a youngster, I used to admire people, people like Dr. M.P. Pai, or even before the Dr. M. Shetty, or Dr. Venkat Rao, or Dr. M. Vichari, and those people. And when I visited Chennai as a small little kid with my grandfather, the most famous doctors were from South Kannada, like Dr. Mohan Rao, or any name you take. When I visited Bombay on a fellowship, I saw Dr. Baliga's name as the foremost among the surgeons in Bombay. When I went for my postgraduate to Delhi, Dr. Mirajkar was the most famous surgeon. He was at the age of 84, but he was still practicing in Delhi, and that is the hierarchy of Dakshina Kannada district. Not only we are known for banks, not only we are known for educational institutions, not only we are known for hotel industry, and there is a famous saying that Shetties are known everywhere, from Miss World to Underworld. So we are known in everything. So that is the hierarchy of Dakshina Kannada district. But the foremost is that we are known, doctors are known from South Kannada. Anywhere you go to United States, you go to United Kingdom, you go to New Zealand, you go to Australia, you will see somebody, a Bhatt or a Shetty or a Pai or a Kamath or a Kulal or somebody from South Kannada who is practicing medicine with the highest elegance. Well, today we are celebrating the great birth anniversary of Dr. B.C. Roy. Yes, rightly, the doctors round the country remember this day as the birthday, and as Dr. K.R. rightly said, the death anniversary of this great man. Apart from what Dr. K.R. also has mentioned, remember, he is the only doctor, I repeat, he is the only doctor who was awarded the Bharata Ratna in our country. Remember, he is the only doctor who was the chief minister of a large state, who was the chief minister for 14 years, and he showed that doctors are not corrupt. And perhaps I do not say that I thought the minister and the MLA will be here. Even that I wanted to tell. He is the only chief minister who was found to be non-corrupt, and that is the greatness of doctors. And Dr. B.C. Roy, when he died, entire house he bequeathed to the society, and it is a hospital which is still running in the city of Calcutta. And that is the greatness of Dr. B.C. Roy. And it is right that we are celebrating his birthday as the Doctor's Day round the country. And it is indeed, we are felicitating doctors who have followed the principles of Dr. B.C. Roy and all these gentlemen. Well, my last, our guest, Dr. Unnikrishnan, rightly mentioned about the COVID. Yes, COVID, nearly 4.1 million people were afflicted in our country, out of which only 5 lakhs died. Whereas in the United States, nearly 20% of the people died at one time. And it was because of you, because of your colleagues, because of your friends, because of doctors who have saved nearly 1 million people otherwise who would have died. And doctors have shown for the first time in our country what doctors can do to the society. And the whole society has woken up that here are doctors, and today they recognize, even today when I got so many telephones, so many on the Doctor's Day, thanking. I was not involved in COVID, I was involved in my own way, but as an administrator, but not in the treatment. But that is our fraternity. And this is a God-given gift to us. This is a God-given gift to us that you and me are doctors. It's a God-given gift to us that we have been practicing medicine with the highest ethics and philosophy. It's a God-given gift that we are happy to be practicing medicine. And we should thank God on this Doctor's Day that He has bestowed this gift to us, and we should utilize it to the fullest extent to practice medicine with the highest ethics and philosophy, more than all with compassion and love. Gentlemen, I again congratulate Dr. Chakrapani and Dr. Pollaya who have led us by lead. Here is a person who is a physician of grace, and he comes here and gives us a recital on flute. That is our fraternity. Congratulations to you, Doctor. And Dr. Pollaya, even at this age, he was few years junior to me in Mysore Medical College. He came and practiced in his own hometown, and she showed what family physicians can do to our country. Thank you, Dr. Pollaya. With this little thought of mine, let us march forwards very firm in our faith. What is important is faith. Faith in ourselves, faith in our society, faith in our commitment, faith in our profession, and march forwards very firm and to lead this country of ours into a great country. Sarve Sukhino Bhavantu, Sarve Santu Niramaya, Sarve Bhadrani Pashantu, Ma Kaschit Dukh Bhav Bhavet. Let all be happy, let none be suffering. Let us all join together to lead on a great life with everyone being happy. Thank you very much.
Thank you, Dr.
ಜನತಾ ಸೇವೆ, ಜನಾರ್ದನ ಸೇವೆ ಎನ್ನುವಂಥ ಈ ಒಂದು ನಿಟ್ಟಿನಲ್ಲಿ ಎಲ್ಲ ವೈದ್ಯರುಗಳು ಬೇರೆ ದಿನ ರೋಗಿಗಳ ಸೇವೆಯಲ್ಲಿ ನಿರತರಾಗಿರ್ತಾರೆ. ಸೊ ಇವತ್ತು ನಮ್ಮ ದಿನ ಇದು. ಎಲ್ಲರೂ ಬಂದು 4 ಗಂಟೆಯಿಂದ ಕಲ್ಚರ್ ಪ್ರೋಗ್ರಾಮ್, ವುಮನ್ ವಿಂಗಿನವರು ಅಮೃತ ಭಂಡಾರಿ ಅಂಡ್ ಟೀಮ್ ಮತ್ತು ಎಲ್ಲ ಟೀಮ್ನವರು ಅತ್ಯುತ್ತಮವಾದಂಥ ಕಲ್ಚರ್ ಪ್ರೋಗ್ರಾಮ್ ನೀಡುವಲ್ಲಿ ಯಶಸ್ವಿಯಾಗಿದ್ದಾರೆ. ನಮ್ಮೆಲ್ಲರ ಮನವನ್ನು ತಣಿಸಿದ್ದಾರೆ. ಒಂದಿನದ ಮಟ್ಟಿಗೆ ಅಂದರೆ ಅರ್ಧ ದಿನದ ಮಟ್ಟಿಗೆ ನಾವೆಲ್ಲ ಏನು ಪ್ರಾಕ್ಟೀಸಿನ ಗೊಂದಲಗಳಿವೆ, ಏನು ಟೆನ್ಷನ್ ಇದೆ, ಅದರಿಂದೆಲ್ಲ ವಿಮುಖರಾಗಿದ್ದೇವೆ ಅಂತ ಭಾವಿಸ್ತೇನೆ. ನಮ್ಮನ್ನು ವೈದ್ಯರನ್ನು ಸೂರ್ಯನಿಗೆ ಹೋಲಿಸ್ತಾರೆ. ಸೂರ್ಯ ಬೆಳಕು ಕೊಡುವಾಗ ಬಡವ, ಬಲ್ಲಿದ, ಶ್ರೀಮಂತ, ಪೊಲಿಟಿಷಿಯನ್ಸ್, ಚೀಫ್ ಮಿನಿಸ್ಟರ್, ಪ್ರೈಮ್ ಮಿನಿಸ್ಟರ್ ಅಂತ ನೋಡುವುದಿಲ್ಲ ಅಂತ. ಎಲ್ಲರಿಗೂ ಒಂದೇ ರೀತಿಯಾದಂಥ ಬೆಳಕನ್ನು ಕೊಡ್ತಾರೆ. ಅದೇ ರೀತಿಯಾಗಿ ನಾವೆಲ್ಲರೂ ರೋಗಿಗಳ ಪಾಲಿಗೆ ಒಂದು ಸೂರ್ಯ ಇದ್ದಾರೆ. ಆ ರೀತಿಯಲ್ಲಿ ನಾವು ಚಿಕಿತ್ಸೆಯನ್ನು ಯಾವ ಜಾತಿ ಮತ ಭೇದವಿಲ್ಲದೆ, ಯಾವುದೇ ರೀತಿಯ ಹಣಕಾಸಿನ ಆರ್ಥಿಕ ಇದನ್ನು ನೋಡದೆ ನಾವು ಚಿಕಿತ್ಸೆಯನ್ನು ಕೊಡ್ತೇವೆ. ಹಾಗಾಗಿ ಇಂಥ ಒಂದು ವೈದ್ಯರ ದಿನವನ್ನು ಈ ಸುಸಂದರ್ಭದಲ್ಲಿ ನಮ್ಮ ವೇದಿಕೆಯಲ್ಲಿರುವಂತಹ ನಾನು ಅನ್ನಯ್ಯ ಕುಲಾಲ್ ಮತ್ತು ಡಾಕ್ಟರ್ ಸೌಮ್ಯ ನಾವು ಕಾರ್ಕಳಕ್ಕೆ ಬೆಳಿಗ್ಗೆ 7 ಗಂಟೆಗೆ ಹೋದವರು 8 ಕಾಲಕ್ಕೆ ಅಲ್ಲಿ ಒಂದು 500 ಜನ ಮಿನಿಸ್ಟರ್ನ ವೆಯ್ಟ್ ಮಾಡ್ತಾಯಿದ್ರು. ಅನ್ನಯ್ಯ ಕುಲಾಲ್ ಒಳಗೆ ಹೋಗಿ ಅವರ PA ಹಿಡಿದು 1 ಮಿನಿಟ್ ನಮಗೆ ಮಾತಾಡಲಿಕ್ಕೆ 1 ಮಿನಿಟ್ ಮಾತಾಡಿದರು. ತುಂಬ ಬ್ಯುಸಿ ಇದ್ರು. ಅವ್ರು ಹೇಳಿದರು ನಮ್ಮದು ಕಾರ್ಕಳ ಪಕ್ಕದವರು, ಅದಕ್ಕೆ ಕೊಪ್ಪ, ತೀರ್ಥಹಳ್ಳಿಯಿಂದ ಕೂಡ ಜನ ಬರ್ತಾರೆ ಅಂತ. ಸೊ ಹಾಗಾಗಿ ತುಂಬ ಅವ್ರು ಬರ್ತೇನೆ ಅಂತ ಹೇಳಿದ್ರು. ಕಾರಣಾಂತರಗಳಿಂದ ಇವತ್ತು ಬೆಳಿಗ್ಗೆ ಬರುವುದಿಲ್ಲ ಅಂತೇಳಿ ಅವ್ರು ಮತ್ತೆ ವೇದವ್ಯಾಸರ ಅಕ್ಕನ ಮಗನಿಗೆ ಮದುವೆ, ಅವರು ನಿನ್ನೆ ಹೋಗಿದ್ದಾರೆ. ಸೊ ಅವರ ಸ್ವಂತ ಅಕ್ಕನ ಮಗನ ಮದುವೆ ಅಂತ ಅವರು ಕುಂದಾಪುರದಿಂದ ಬರಬೇಕು. ಕುಂದಾಪುರದಿಂದ ಬರೋ ತಡವಾಗ್ತದೆ, ನೀವು ಮುಂದುವರಿಸಿ ಅಂತ ಹೇಳಿದರು. ಸೊ ಹಾಗಾಗಿ ನಮಗೆ ಡಾಕ್ಟರ್ ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿ ಮತ್ತು ಉನ್ನಿಕೃಷ್ಣ ನಾವು ಗೆಸ್ಟ್ ಆಗಿ ಮಾಡಿದ್ದೆ. ಅದಕ್ಕೆ ಎಲ್ಲಾದರೂ ಮಿನಿಸ್ಟ್ರು ಆದರೆ ನಮ್ಮಲ್ಲಿ ಒಬ್ಬರು ಗಣ್ಯ ವ್ಯಕ್ತಿಗಳು ಬೇಕು, ಅಥವಾ ಮಿನಿಸ್ಟ್ರು ಬಂದರೆ ನಮ್ಮಲ್ಲಿ ಕೂಡ ಒಬ್ಬರು ಗಣ್ಯ ವ್ಯಕ್ತಿಗಳಿಬ್ಬರು ಇರಬೇಕು. ಯಾಕಂದರೆ ಆ ಸ್ಥಾನಕ್ಕೆ, ಆ ಸ್ಟೇಜಿಗೆ ಒಂದು ಘನತೆ ಬರಬೇಕಂತೇಳಿ ನಾವು ನಮ್ಮ ಸತ್ಯಮೂರ್ತಿ ಐತಾಳ್ ಮತ್ತು ನಾವೆಲ್ಲ ಸೇರಿ ನಾವು ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿಗೆ ಬರಬೇಕು ಅಂತೇಳಿ ನಾವು ಆಯ್ಕೆ ಮಾಡಿದ್ದಾರೆ. ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿಯವರು 97ರಲ್ಲಿ ವೆಲ್ಲಾಕನ್ನು ಬಿಟ್ಟಿದ್ದಾರೆ. ನಾನು 2002ರಲ್ಲಿ ನಮ್ಮ ಬೆಳ್ತಂಗಡಿ ತಾಲೂಕಿನ ಒಂದು ಪೇಷಂಟ್ ಅಡ್ಮಿಟ್ ಆಗಿದ್ದು, ನೋಡ್ಲಿಕ್ಕೆ ಹೋಗಿದ್ದೆ. ನಾನು ಕೇಳಿದೆ ನಿಮ್ಮ ಡಾಕ್ಟ್ರ್ ಯಾರು? ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿ ಅಂತ ಹೇಳಿದ್ರು. ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿ ಬಿಟ್ಟು 5 ವರ್ಷ ಆಗಿದೆ. ಈಗಲೂ ಕೂಡ ವಾರ್ಡಲ್ಲಿ ಕೇಳಿದರೆ ಪೇಷಂಟ್ ಡಾಕ್ಟ್ರ್ ಯಾರು ಅಂತ ಕೇಳಿದ್ರು, ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿ. ಮೊನ್ನೆ ನಾನು ಬೆಳ್ತಂಗಡಿಗೆ ಒಂದು ಸ್ಕೂಲಿಗೆ ಹೋಗಿದ್ದೆ. ನಾನು ಗೆಸ್ಟಾಗಿ ನಮ್ಮೂರು ಬೆಳ್ತಂಗಡಿ ತಾಲೂಕಿನಲ್ಲಿ ಗೆಸ್ಟಾಗಿ ಹೋಗಿ ಕೇಳಿದೆ, ಏನಾಗ್ತೀರಿ ಅಂತ ಕೇಳಿದ್ರೆ ಮಕ್ಕಳಲ್ಲಿ, ಹೈಸ್ಕೂಲ್ ಮಕ್ಕಳಲ್ಲಿ ಡಾಕ್ಟರ್ ಆಗಬೇಕು ಅಂತ. ಏನಾಗ್ತೀರಿ ಡಾಕ್ಟರ್ ಆಗಿ ಅಂತ ಹೇಳಿದ್ರೆ ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿ ಥರ ಆಗಬೇಕು. ಅಂದರೆ ಇದರ ಇಂಪ್ಯಾಕ್ಟ್ ಇಷ್ಟೊಂದು ಸಾಮಾಜಿಕವಾಗಿ ವೈದ್ಯರಾಗಿ ಇಷ್ಟೊಂದು ಇಂಪ್ಯಾಕ್ಟ್ ಮಾಡಿದರೆ ಅಂದರೆ ಅದು ದೊಡ್ಡ ನಿಮ್ಮ ಒಂದು ದೇವರ ಆಶೀರ್ವಾದ. ಪೇಷಂಟ್ಗಳೆಲ್ಲ ಬಂದು ಹೇಳ್ತಾರೆ ಇದು ಶಾಂತರಾಮ್ ಶೆಟ್ಲೆ ಕಾವಡು ದಾಯಿ 12 ಪುಂಡಲ್ಲಿ ಒಂದೇಲ ಕೆಂಪು. ಸೊ ಇದೆಲ್ಲ ಅಂದರೆ ರೋಗಿಗಳು ಹೇಳಿದಂಥ ಮಾತು. ಹಾಗಾಗಿ ನಿಮ್ಮಂಥ ವ್ಯಕ್ತಿಯನ್ನು ನಾವು ಇವತ್ತು ಕರೆದದ್ದು ಬಹುಶಃ ಈ ಒಂದು ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಒಂದು ದೊಡ್ಡ ಒಂದು ತೇಜಸ್ಸನ್ನು ಕೊಟ್ಟಿದೆ, ಸಂಭ್ರಮವನ್ನು ನೀಡಿದೆ ಅಂತ ಭಾವಿಸ್ತೇನೆ. ಹಾಗಾಗಿ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಬಂದು ಉತ್ತಮವಾದಂಥ ನಿಮ್ಮ ಒಂದು ಹಿತವಚನವನ್ನು ಹೇಳಿದಿರಿ. ನಿಮಗೆ ಅನಂತ ಧನ್ಯವಾದಗಳು. ಡಾಕ್ಟರ್ ಉನ್ನಿಕೃಷ್ಣನ್, ಡೀನ್ ಆಫ್ KMC ಮ್ಯಾಂಗ್ಳೂರು, ಇವರ ಹತ್ರ ಕೂಡ ನಾವು ಹೋದಾಗ ಇಮಿಡಿಯೇಟ್ ಆಗಿ ವಿದಿನ್ ವೀಕಲ್ಲಿ ಸುಶಾಂತನನ್ನು ಕರೆಸಿ ನಮ್ಮ ಮೆಂಬರ್ ಆಗಿದ್ದಾರೆ. ನಮ್ದು ಈಗ 16,000 ಕೊಟ್ಟು ಮೆಂಬರ್ ಆಗಿದ್ದಾರೆ. ಜೊತೆಗೆ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಬಂದಿದ್ದಾರೆ, ಟೈಮಿಗೆ ಬಂದಿದ್ದಾರೆ. ಸೊ ಹಾಗಾಗಿ ನಿಮಗೂ ಕೂಡ 7 ಗಂಟೆಗೆ ಇದ್ರು ಅವರು. ಜೊತೆಗೆ ಶಾಂತರಾಮ್ ಶೆಟ್ಟಿ ಕೂಡ ಅವರು ಇಲ್ಲಿ ರೋಡ್ ಸ್ವಲ್ಪ ಸಣ್ಣದು, ಆ ಕಡೆ ಬರಲಿಕ್ಕೆ ಬಂದರೆ ಸ್ವಲ್ಪ ಬ್ಲಾಕ್ ಆಗ್ತದೆ. ಸೊ 7:05ಕ್ಕೆ ಸರ್ ಬಂದಿದ್ದಾರೆ. ಸೊ ಹಾಗಾಗಿ ನಮ್ಮ ಡೀನ್ ಆದಂಥ ಉನ್ನಿಕೃಷ್ಣನ್ ಅವರಿಗೂ ನಮ್ಮೆಲ್ಲರ IMA ಪರವಾಗಿ ಅನಂತ ಧನ್ಯವಾದಗಳು. ಹಾಗೂ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಇವತ್ತು ಸನ್ಮಾನಿಸಲ್ಪಟ್ಟಂಥ ಸೀನಿಯರ್ ಯುರಾಲಜಿಸ್ಟ್ ಆದಂಥ MC ಸುವರ್ಣ ಹಾಗೂ ಸೀನಿಯರ್ ಸೈಕ್ಯಾಟ್ರಿಸ್ಟ್ ಆದ ಡೆನ್ಸಿಲ್ ಪಿಂಟು ಹಾಗೂ JN ಭಟ್ ಇವರಿಗೂ ಕೂಡ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ನಿಮಗೆ ಸನ್ಮಾನ ಮಾಡಿದ್ದು ನಮ್ಮ ಯುವ ವೈದ್ಯರಿಗೆ ಅದೊಂದು ಸ್ಫೂರ್ತಿಯಾಗಲಿ ಅಂತ ಭಾವಿಸಿದ. ಸೊ ನಿಮಗೂ ಈ ಕಾರ್ಯಕ್ರಮಕ್ಕೆ ಬಂದದಕ್ಕೆ ಧನ್ಯವಾದಗಳು. ಹಾಗೆ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ವೇದಿಕೆಯಲ್ಲಿರುವ KR ಕಾಮತ್, ನಮ್ಮ ಅಧ್ಯಕ್ಷರಾದಂಥ ಸತ್ಯಮೂರ್ತಿ ಅಣ್ಣಯ್ಯ ಕುಲಾಲ್, ದಿವಾಕರ್ ರಾವ್ ಹಾಗೂ ನಮ್ಮ GK ಭಟ್ ಇವರಿಗೂ ಕೂಡ ಅನಂತ ಧನ್ಯವಾದಗಳು. ನಾವು ದಿವಾಕರ್ ರಾವ್ 2 ದಿನದ ಹಿಂದೆ ಇಲ್ಲಿ ಸೋರ್ತಾ ಸ್ವಲ್ಪ ಅಲ್ಲಿ ಇದಾಗಿದೆ, ಬಹುಶಃ ಅವರು 2 ಸಲ ಬಂದು ನೋಡಿ ಹೋಗಿದ್ದಾರೆ. ಏನಾದರೂ ಶಾರ್ಟ್ ಸರ್ಕ್ಯೂಟ್ ಆಗ್ತದಾ ಪರ್ಸನಲಿ ನೋಡಿ ಹೋಗಿದ್ದಾರೆ. ಹಾಗಾಗಿ ನೀವು ಈ ವಯಸ್ಸಿನಲ್ಲಿ ನಿಮ್ಮ ಈ ಕಾಳಜಿ ಇದೆಯಲ್ಲ, ಅದು ಅಭಿನಂದನೀಯ ಅಂತ ಹೇಳ್ತಾ ನಿಮಗೂ ಕೂಡ ಧನ್ಯವಾದವನ್ನು ಸಮರ್ಪಿಸ್ತೇನೆ. ಹಾಗೆ ಈ ಕಾರ್ಯಕ್ರಮವನ್ನು ನಡೆಸಿಕೊಟ್ಟವರು ಡಾಕ್ಟರ್ ಸೌಮ್ಯ ಜೊತೆಗೆ ಸುನೀಲ್ ದತ್ತನ್ನ. ಸೊ ಇವರಿಗೂ ಕೂಡ ಅತ್ಯುತ್ತಮವಾಗಿ ನಡೆಸಿಕೊಟ್ಟಿದ್ದೀರಿ. ನಿಮಗೂ ಕೂಡ ನಮ್ಮ IMA ಪರವಾಗಿ ಧನ್ಯವಾದಗಳು. ಸೊ ಈ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಮಾಧ್ಯಮ ಮಿತ್ರರಿದ್ದಾರೆ, ಉದಯ್ ಶಂಕರ್ ಅವರು ಇದ್ದಾರೆ. ಅವರಿಗೂ ಕೂಡ ನಮ್ಮ ಈ ಕಾರ್ಯಕ್ರಮದ ವಿವರವನ್ನು ಎಲ್ಲ ಪತ್ರಿಕೆಗಳಿಗೆ ನೀಡಲಿಕ್ಕಿದ್ದಾರೆ. ಸೊ ಅವರಿಗೂ ಕೂಡ ಅನಂತ ಧನ್ಯವಾದಗಳು. ಸೊ ಹಾಗೆ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮ ಯಶಸ್ವಿಯಾಗಿ ನಡೀಬೇಕಾದ್ರೆ KMC ಅವರು ಸ್ಪಾನ್ಸರ್ ಮಾಡಿದ್ದಾರೆ. CME ಜೊತೆಗೆ ಇದಕ್ಕೆ ನಮಗೆ ಆರ್ಥಿಕ ನೆರವನ್ನು ಕೂಡ ನೀಡಿದ್ದಾರೆ. ಜೊತೆಗೆ ಹೊಂಡಾ ಕಾರಿನವರು ಅವರು ಕೂಡ ನಮಗೆ ಆರ್ಥಿಕ ನೆರವನ್ನು ನೀಡಿದ್ದಾರೆ. ಸೊ ಅವರಿಗೂ ಕೂಡ ನಾವು ಧನ್ಯವಾದವನ್ನು IMA ವತಿಯಿಂದ ನೀಡ್ತಾ ಇದ್ದೀವಿ. ಸೊ ಎಲ್ಲಕ್ಕಿಂತ ಮುಖ್ಯವಾಗಿ ನಮ್ಮ ಎಲ್ಲ ಕಾರ್ಯಕ್ರಮಗಳಿಗೆ ಬಹುಶಃ ಅಲ್ಲಿ ಹೊರಗೆ 150ರಿಂದ 160 ಜನ ಇವತ್ತಿನ ಕಾರ್ಯಕ್ರಮದಲ್ಲಿ ಭಾಗವಹಿಸಿದ್ದಾರೆ. ಈ ಕಾರ್ಯಕ್ರಮ ಚೆಂದ ಆಗಬೇಕಾದ್ರೆ ಭಾಗವಹಿಸುವಂಥ ಎಲ್ಲ ವೈದ್ಯರು ಕಾರಣ ಅಂತ ಹೇಳ್ತಾ ನಿಮಗೆಲ್ಲರಿಗೂ ವಂದಿಸ್ತಾ ನನ್ನ 2 ಮಾತನ್ನು ಮುಗಿಸಿ.